Good morning, everyone. Thank you for being here with Insight Memory Care Center for our Fall Caregiver Bootcamp. My name is Lindsay, and I'm the Director of Education and Outreach at Insight. And also with me, I have Marquita Brown, our Outreach and Support Coordinator. So we will be happy to kind of facilitate through this morning of important information for all caregivers of individuals living with dementia. If you are new to Insight Memory Care Center, our mission is to provide specialized care, support, and education for individuals living with Alzheimer's and other memory impairments, their families, their caregivers, and the community through our Adult Day Health and Resource Center. Our vision is a community where those affected by Alzheimer's and other memory impairments can achieve the highest quality of life. And Insight it enhances our mission through a variety of different programs, from our Adult Day program for those living with dementia, our early stage programs to provide social engagement, classes and consultations for caregivers, support groups, memory screenings, and lots of other ways that we support families and those living with the disease. And this morning for our Caregiver Bootcamp, our agenda will be that for the first 15 minutes or so, we'll be going through a variety of welcome announcements. I will say that today's bootcamp is being recorded, so if you do need to step away at any point, rest assured you will receive access to the recording later on and can catch up. Then at 9:15, we'll hear from Dr. Bicksel about understanding a dementia diagnosis and treatment. We'll take a quick 5-minute break. 10:20, we'll hear from Tom West about managing someone else's money. Another quick break. And then at 11:25, a panel of caregivers who are going to be sharing things that they wish they would have known earlier on in the journey, followed by just a few closing comments. And this boot camp wouldn't be possible without the support of our wonderful sponsors and community partners. And I would like to invite Elizabeth to come online with us from Capital City Nurses to share a bit more about this important organization in our community.
Good morning, everyone. My name is Elizabeth Mako, and I am the Senior Home Care Specialist for Capital City Nurses here in Northern Virginia. For some of you who may be familiar with some other home cares in the area, we just rebranded our Northern Virginia offices from Ready Hands and Allegiance Home Care to Capital City Nurses in June to unify our DC and Maryland office, who's been going by Capital City Nurses for 45 years. Started in Chevy Chase by a nurse. Sorry, I have some alerts going off here. We provide private duty caregiving services and private duty nursing services wherever someone may call home. We do work with patients who with a variety of disease processes. So that may be dementia, Parkinson's, somebody who is post-surgical, somebody who just may need some more companionship or may benefit from more companionship in the home. And you can find out some more information about us at capitalcitynurses.com. We'd be happy to provide any sort of resource to anyone out there looking for some more information.
All right, thank you so much, Elizabeth and Capital City Nurses, for being one of our sponsors for Caregiver Bootcamp today. And I'd like to invite in our other sponsor from Brandywine Living in Alexandria. Welcome, Courtney.
You're on mute, Courtney.
There we go. Good morning. Is that better? Good morning. I wanted to certainly wish a warm and send a warm welcome on behalf of Brandywine Living at Alexandria. We are Alexandria's premier luxury assisted living and memory care community. We were built from the ground up in 2018, and so we were able to open our doors and still consider ourselves relatively new. We are always excited to be able to partner with Insight. Both Lindsay and Marquita are instrumental in making the program so successful. And we are excited to be able to start a 3-part dementia speaker series that's going to be coming up and hosted at Brandywine Living, kicking off October 7th. We're excited to be able to welcome anyone that might be impacted by dementia so that we can provide some resources and have a nice open dialogue. As a result of our community being very connected to the community in Alexandria, we are always excited to be able to provide resources and additional support to caregivers. And if there are families that are on this, on the boot camp this morning that have additional questions, I certainly want to provide my email in the chat. If we can provide any additional resources or talk to any families that may be looking for making a transition into an assisted living or memory care environment, we'd love to talk with you. Again, thank you so much for being a part of today's boot camp, and looking forward to a great morning.
Thank you so much, Courtney, and to Brandywine Living at Alexandria for being one of our bootcamp sponsors. We really appreciate you. And I'm glad that Courtney mentioned the chat. I forgot to say that in the beginning. So for everyone who's listening in today, if you have comments that you want to make or want to see some of the links that our sponsors or speakers might be providing, those will be in the chat. But also, if you have questions for our speakers this morning, please put those in the Q&A function in Zoom. We'll be watching the Q&A much more closely for those questions that our speakers will be able to address. And next, I'd like to invite in Dr. Emily Ihara from George Mason University to tell us about a couple of exciting opportunities to get involved in their research.
Thank you, Lindsay. Good morning, everyone. I am, as Lindsay said, my name is Emily Ihara. I am the chair of the Department of Social Work at George Mason University, and we have a strong gerontological research team. And we've been partnering with Insight for probably, I don't know, almost a decade maybe, on various initiatives. And we are working right now on some exciting caregiver research, because we know that caregivers of people living with dementia face a lot of different things, right? So the first study I wanted to talk about was the collaborative care planning study. And so that's the words on your left, right? So this, we're targeting people, caregivers of individuals living with mild cognitive impairment or early to moderate stage dementia. And it's pretty simple, actually. We're basically, what you're gonna do is, talk to us for 3 times, up to 30-minute interviews. We have some great research assistants. And so actually, hopefully it's a fun experience. For those who are able to complete all 3 interviews, we are offering a $75 incentive in gift cards. And we are hoping to get that started fairly soon. So if you are interested, I'm going to put the link in the chat. This is a link to a survey where you'll just answer a few questions, and you can, and then we'll be in contact with you. We can do this all virtually, so there's no worries. But if you prefer, we also can come to Insight and do it in person. So, or anywhere else that you feel comfortable. So that is the collaborative care planning study. And then the second thing that we're doing, so we will be starting another study in January called stress busting, where we can, we're going to be providing an educational program about stress management techniques. But what we want to do in the next couple of weeks is we're starting a smaller group. So we just need a couple of volunteers to join us. That's starting on October 11th on Monday nights from 5:30 to 7. So if you are interested in that, you can email us. Let's see. I know my email. I think this is what it is. So we have an email address that should go to, you can, if either of these studies are of interest to you, you can email us there. You can also email me. Again, my name is Emily Ihara, and I'm going to put my email in the chat. but you can also do both of these things. So hopefully if they both interest you, the first one, again, will be very minimal time commitment. And then the stress busting program is an educational program. And then we'll have a much bigger recruitment that we'll be rolling out for January. So thank you.
Thank you so much, Dr. Ihara. And I do encourage all of you listening, if either of these opportunities seem like something you're curious about or interested in, please do participate in them. They're just really great opportunities to contribute to research and also to get to know other caregivers and people working in this caregiving field and learning. So please do join these two opportunities through George Mason University. And my last announcement this morning is I wanted to let you know about a fabulous conference coming up in November. This is the 35th Annual Caregivers Conference provided by the Northern Virginia Dementia Care Consortium. This year's theme is Caregiving as Memories Fade. Our keynote speaker is Dr. Gary Chapman, who wrote the book about the 5 love languages and also co-wrote a book about applying the 5 love languages to the Alzheimer's journey. We'll have a doctor from UCLA sharing about challenging behavioral changes, a doctor from Johns Hopkins sharing about younger onset dementia, and also some really fun mini sessions focusing on chair exercises, on music therapy, and on using Legos, Lego play. So please join us for this great conference. It will be on Zoom. It'll be virtual, November 9th through the 11th. From 10 until 12:30 each day. So if you'd like to see the full program or purchase a ticket to participate, please visit nvdcc.com, which I'll plug into the chat in just a moment. And now we're ready for our first session of the morning, Understanding Dementia Diagnosis and Treatment. And we are lucky to have with us Dr. James Bicksel, who is board certified in neurology and clinical neurophysiology by the American Board of Neurology and Psychiatry. He's certified in behavioral neurology and neuropsychiatry by the United Council for Neurologic Subspecialties. And he works at Capital Neurology Services in McLean. That's where you'll find him from day to day. And Dr. Bicksel has been a fabulous resource to us at Insight and to many of the families that we serve. So, Dr. Bicksel, welcome this morning. And I'm going to let Dr. Bicksel go ahead and share his own screen.
All right. Thank you, Lindsay. I'm going to share my screen here. All right, there it is. So I'll presume everyone can hear me. I can't hear or see you. I'll presume everyone can hear me.
We can hear you, but we don't see your screen yet.
You do not see my screen. Okay. All right, hold on just a moment. All right, let me try this.
Oh, I see someone in the chat saying they can see his screen at home.
Oh.
Oh, I see your screen now. I see your email.
Okay, yes, we'll put my email down. So you don't have to see my email. And we will start the PowerPoint presentation. Can people see that?
I'm still seeing your email. Marquita, do you see anything different?
Let's see, how about now?
No, I see the same thing, just the email.
Okay, well, I think we're just gonna let Lindsay put it up then. Lindsay
Okay.
will take over and I will stop sharing my screen.
All right, here we go, 1 sec. Oops.
Of course, worked a minute ago.
I know, isn't that how it goes, Dr.
That's how
Bicksel?
it goes, that's how it goes, yeah.
All right, I'll be here in the background advancing your slides on your cue.
All right, so my name is Dr. Jim Bicksel. As Lindsay said, I'm a neurologist. I specialize in Alzheimer's disease. My office is in McLean, and I'm going to try to tell you today about a little bit about dementia, Alzheimer's, and some of the new treatments. And I'm going to try to move through the slides a little bit quickly because I know people are going to have a lot of questions about the new treatments. So next slide. So it's on the rise. Everyone knows that. Next slide. Next slide. All right. So we know it's a big problem. We wouldn't be here if it wasn't a big problem. So how are we going to approach the idea of dementia? And the first thing is, when we talk about any kind of cognitive decline, age-related cognitive decline, the question becomes, is it normal or is it a disease? Next slide. And people come to me, very worried about some normal changes of aging, thinking that this means that they're developing Alzheimer's disease. But that's certainly just not always the case. Normal aging can involve things like having to read something several times, going into a room, forgetting why you went there. That's the classic one. Trouble remembering people's names on meeting them, even close family members sometimes, and trouble finding words or names when talking, but then you tend to remember them later. That's one of the big things I always ask people. Well, did you remember it later? Yes, I remembered it later. That usually indicates, it's there. You're just having trouble accessing it, which is part of normal aging. What makes the disease pathological is asking the same question several times a day, telling the same story or the same thing over and over again, forgetting a lot of details or important details of recent events, losing your way in familiar environments, not finding your car, trouble keeping appointments, and then if it's a visual thing, trouble interpreting images as well. Next slide. So when we think about dementia or cognitive impairment, you kind of have to think about it down two routes, and one is the clinical route, and the other is the disease process in the brain route. And you'll see that those don't always match up. So when we're talking about cognitive impairment, trouble with people's ability to think, we divide that into different cognitive domains that are pretty familiar and pretty intuitive. Memory is one, visual spatial ability is another, attention, speech and language is another one that you just think of as these are different ways of categorizing the way that we think. Next slide. But then the causes of that cognitive impairment can be varied. So it can be different types of dementias. We see Parkinson's and frontotemporal dementia here, and Lewy body. Then at the bottom, we see Alzheimer's, but we also see things like normal pressure hydrocephalus, drugs and alcohol, depression, strokes. So there are a lot of things besides degenerative progressive dementia that can cause cognitive impairment. Next slide. And so then you say, well, what is dementia? Is it the same as Alzheimer's disease? What makes the difference? We know that we've got trouble with cognitive function, and we think there's some pathological cause. What is it actually? Next slide. And dementia itself is just an umbrella term for any type of neurodegenerative disease where part of the brain deteriorates faster than the rest. And that can happen with any of those cognitive domains. Like I said, language, visual, spatial, behavior. Memory is the most common one, and that's Alzheimer's disease. So under the umbrella there, you see Alzheimer's, the most common, about 70 or more % of all dementias. But then Parkinson's, Huntington's is there, Wernicke-Korsakoff, which is alcohol-related degeneration. Those can all cause cognitive decline that's abnormal as well. Next slide. And then mild cognitive impairment is a separate thing that we used to think of as possibly a category of its own. Now we tend to think of it more likely as probably the preliminary stage of a degenerative dementia. But mild cognitive impairment can affect any domain, but if it's dementia, it tends to affect the one domain that it's eventually going to blossom into that type of dementia. So we define mild cognitive impairment just the way we define dementias, by the cognitive domain that's affected. And that gives you amnestic MCI, just affecting memory, and non-amnestic MCI. And mild cognitive impairment by definition is just one cognitive domain and not impacting activities of daily living. So when it spreads out to more than one cognitive domain and it starts to involve activities of daily living and really impact function, that's when we say that it's gone from mild cognitive impairment to Alzheimer's. And MCI is kind of a slightly slippery term. I mean, when it came out initially 15 years ago or so, it was thought to maybe be a category of its own. And I do have people who have mild cognitive impairment who have stayed pretty stable for 10 years. They're not they're not progressing, so they do not have a progressive degenerative dementia. They just have some impairment in a cognitive domain beyond what's expected for age. Next slide. So does everyone with abnormal memory loss have Alzheimer's disease? And if you hit the next slide thing, it ought to come up and say, of course not. All of those different things that we talked about earlier can cause cognitive decline. And all those things can cause cognitive decline in different domains, also can cause memory. We're going to start to focus more on memory and Alzheimer's disease. Next slide. So how do you categorize the dementias? Next slide. Well, again, just like with cognitive domains and causes, you can categorize them by the clinical picture or by the pathology, that is the disease in the brain that causes it, and those don't always match up. So for Alzheimer's disease, that's the most common, and that's the one with gradual onset of cognitive symptoms, memory problems, and otherwise well individuals, often beginning with amnestic MCI. There's frontotemporal dementia, which is a language, which has got two forms, a language variant and a behavioral variant. And in red there, it says logopenic primary progressive aphasia, which is a mouthful. But the important point is that even though that's classified as a frontotemporal dementia, primarily affecting language, the pathology, the changes in the brain that cause it, are the same as Alzheimer's disease. So that is now considered a subtype of Alzheimer's disease. And it depends on whether or not you've got those changes in the brain that are typical for Alzheimer's. And we're going to go through and see those. Lewy body disease, characteristic type of presentation, and vascular dementia also fairly characteristic. Next slide. So then you try to categorize it by the cellular change in the brain. And Alzheimer's is any dementia that's caused by plaques and tangles in the brain. And that logopenic variant primary progressive aphasia we see is due to those plaques and tangles. Parkinsonian dementia and Lewy body disease is due to a different pathology in the brain. It's caused by proteins called alpha-synuclein, which also destroy brain tissue. And then vascular dementia is just caused by stroke. Stroke in a certain part of the brain, it can affect memory, visual spatial ability, language, any of those things that's caused that you get with a stroke. Next slide. So now let's focus in on Alzheimer's disease, and we know we can talk about it as dementia of the Alzheimer's type. So we know what dementia is and what Alzheimer's is, and we're going to focus in on Alzheimer's now. Next slide. So a short history of Alzheimer's. Before Dr. Alzheimer categorized this, most of these things were thought to be normal aging, and it was simply known as senility. But we know now that that is not the case. It is not, okay, sorry. So it is not the case that this happens automatically as you grow older. People should retain their cognitive ability as they grow older, except for those normal changes we talked about earlier. And when you don't, then that's abnormal. It's not just senility. Next slide. And this was his first patient. He found a group of patients with this cluster of symptoms, starting with memory loss, beyond what's normal for age and progressing, then eventually to all cognitive domains and eventually to death. Next slide. And this is what he saw under the microscope. The history of medicine kind of follows the history of microscopy, and in particular the stains that we have, because you can take a bit of brain tissue, you can look at it under the microscope, but you might just see cells. If you can have a stain, that is a chemical that's going to bind to particular proteins, then you can look at that under the microscope, and these abnormal proteins kind of light up. They're tagged by that stain. And that allowed him to see that there were certain things that were the same in all of these people. And that was those amyloid plaques we're going to talk about. Next slide. So we ended up with the amyloid hypothesis, which is still alive and well. And that basically says that there's a progression of this, beginning with the amyloid plaques, and then tau tangles, and then eventually neurodegeneration, which is atrophy, actual wasting of the brain. Next slide. And Lindsay, can you go a couple up, go 2 slides up for me? One more, there we go. So this is what happens, and then we'll go back to, and you'll see the bigger picture. A membrane on the left, just a cell there on the left, and there's a normal transmembrane protein called amyloid precursor protein, and it is cleaved by enzymes to create a protein that is normal and used for normal function. But if it is cleaved in the wrong place by incorrect enzymes, then it creates an insoluble plaque that precipitates and interferes with the communication of nerve cells between each other. And if you go back now, Lindsay, 2 slides, you'll see a more kind of representative image of it with the nerves around there. And then this big nasty plaque right in the middle, preventing them from talking to each other and communicating. Next slide, let's go 2 more, 1 more, and then again, and let's go 1 more, please. So when that happens, nerve cells, their only job is to communicate with each other. And whenever you've got that plaque between them and they can't communicate, then they begin to die. And this is a nerve cell on the left there, and a nerve cell begins with a cell body there, and then a signal is passed down this axon. And in order for that to happen and for there to be transmission of a signal to the next nerve, you have to have neurotransmitters that go along these microtubules. And those microtubules are made up of a protein called tau. And whenever the cell cannot transfer its signals from one to the other, then those proteins become abnormal. They become phosphorylated, and all that means is just that they can no longer form that nice tube that you see at the top there that's able to transmit that neurotransmitter vesicle down the axon. And instead, like the second picture below, it breaks apart and it disintegrates. And then at the bottom, you see that whenever it disintegrates enough, then the cell dies. Next slide. And when the cell dies, you get the next part of this ATN, amyloid tau neurodegeneration, and that's just wasting away of the brain. Then that's the brain actually begins to die. And you've got a healthy brain on the left, severe AD on the right. And the important thing to note there is that severe AD, it's affecting the entire brain, not just the part that involves memory. So this is a disease that spreads. On the right panel there, you see preclinical mild to moderate severe AD, and you see it starts in that part of the brain where new memories are formed called the hippocampus. And it kind of spreads out from there, and eventually it involves the entire brain. And that's why it really ends up being fatal eventually if nothing else intervenes, because it's eventually even going to involve brainstem and the ability to swallow and breathe and move and things like that. Next slide. So this is kind of the way it works, the amyloid beta accumulation, the synaptic dysfunction, that is the cells can't communicate with each other, the tangle formation, that abnormal tau inside the cell, and then eventually the cell death. And then you have to have all of that before you actually get cognitive decline. We have an enormous amount of cognitive reserve. We can lose a lot of brain and still, not even really notice much of a difference in our thinking. Next slide. And let's go to the next slide. So this is the idea that plaques and tangles develop 10 to 20 years before the changes in cognition. And this is a biomarker type of imaging that we will talk about in just a moment. But that is the continuum from normal to a preclinical stage with amyloid beta, and then eventually tau, and then eventually neurodegeneration. Next slide. So we'll go through this kind of quickly. Again, it's just the idea that that you can have Alzheimer's before you actually begin to have clinical symptoms. Now, that's a tricky thing because not everybody who has these plaques and tangles, plaques in particular, is going to develop Alzheimer's disease. There are a lot of people, not a lot, but there are people who have plenty of plaques and their cognition is perfectly normal right up until the end. So there's just not a clear one-to-one correlation between these pathological changes and the cognitive function that someone has. And so we have to be very careful when we talk about different risks for Alzheimer's. There's preclinical Alzheimer's, which you'd think of as, any time the plaques begin to form all the way up until you have memory issues. But then you can separate them by pre-symptomatic and at risk. So pre-symptomatic is there are rare genetic mutations that guarantee you're going to have Alzheimer's disease. And it just, the plaques and tangles are going to give you Alzheimer's if you have one of these rare genetic mutations. And so we think of that as truly pre-symptomatic. Even if you don't have memory issues now, we know you're going to get them. The second group would be at risk. So they've got the plaques and tangles. You might see those in the biomarkers that we're going to talk about in just a minute, but they do not, we're not going to say they have preclinical Alzheimer's, because they might be one of those people who has a lot of plaques, but still their thinking is fine all the way to the end. Next slide. So eventually you end up with kind of this change in the way we define mild cognitive impairment. I said earlier, we think of it, it's supposed to be a condition that might last and not change, but more and more we're thinking of mild cognitive impairment as prodromal Alzheimer's, meaning the beginning stages, something that's going to develop into Alzheimer's. Next slide. And so this is kind of why those why the clinical symptoms and the pathology, the brain changes, don't always match. And how do we try to match that stuff up? Well, there's typical Alzheimer's disease, which is episodic memory loss, is the dominant feature caused by the amyloid pathology. But if you don't have that amyloid, then you get a strange thing called SNAP, suspected non-amyloid pathology Alzheimer's disease. You've got the clinical symptoms of it, but you don't have the plaques. Then there's atypical Alzheimer's disease caused by the plaques, but it doesn't necessarily start with that classic memory loss of the Alzheimer's type, trouble forming new episodic memories. And those are different things like the logopenic aphasia. There's a frontal variant cortical atrophy. There's posterior cortical atrophy where people initially present with trouble with vision, and they end up with neuro-ophthalmologists and they say, hey, your eyes are fine and you don't have a stroke. And it turns out that those plaques and tangles have just decided they're going to deposit first in the visual part of the brain instead of the memory part of the brain. And then mixed dementia fulfills all the criteria for Alzheimer's, but there's also something else impacting it like strokes, vascular disease, things like that. Next slide. So why have the clinical trials failed? Yeah, it's a big news now. Aducanumab is the big thing. It's changed my world. And it is the result of a lot of clinical trials, most of which have failed and billions of dollars sunk down the tube of clinical research with nothing to show for it. And one of the big reasons was because before we were able to tell about these plaques and tangles in life, we could only select people for trials based on their symptoms. And so you've got, all these different possible causes, all giving what looks like the same clinical syndrome, and you give your drug that's supposed to help amyloid, that's supposed to take away amyloid plaques to somebody whose memory loss is actually due to stroke or Parkinson's disease. And of course, it's not going to work. Next slide. So next slide. So this is that same slide again, that ATN, amyloid plaques, tau tangles, neurodegeneration. And if this is truly the temporal cascade, the time frame of it, then you want to intervene as soon as you can. And the first stage is the deposition of the amyloid plaques. If that is indeed what kicks off that process, then eventually ends in full-blown Alzheimer's. Next slide. So now we have biomarkers of Alzheimer's disease. So the research was transformed by the fact that maybe 10 years ago or so, we started to be able to find out your amyloid status, whether you had the amyloid or not, during life, rather than waiting for you to die and then looking at a piece of your brain under a microscope, the way Dr. Alzheimer's did over 100 years ago. And there are there are several ways to do that. The amyloid plaques you can see with amyloid PET scans we'll talk about. You can also look at spinal fluid. The tau tangles you can see with now tau PET scans, which are only used in research. And then the neurodegeneration you can see on a regular MRI brain if you get the proper sequence called neuroquant that will quantify the size of the hippocampus. And we're going to see that in a moment. Next slide. So the imaging biomarkers, the PET scans, there are two types. But So there are two types. A PET scan is something that's usually used in cancer, and usually the abnormal cells are tagged with a radioactive type of glucose. And because cancer cells are very metabolically active, they take up this glucose very avidly, and then you take a picture of it and you see this concentration of glucose in the area where the cancer is. And you can kind of do it the other way around by, instead of looking for a lot of glucose uptake, you can look for less glucose uptake, less than normal. And if you've got a part of the brain, the part that forms memories, that's not taking up enough glucose, not metabolically active, then you'd say there's something wrong with that. Now, that's a hard thing to do because a metabolic PET scan looking at glucose uptake is not geared for degenerative diseases looking for a reduction in uptake. It's more geared for cancerous diseases looking for an increase in uptake by very metabolically active cells. So we now have PET ligands, and those, like the glucose that tags to the metabolically active cells in the glucose PET scan, these now tag to the amyloid plaque itself. So just like Dr. Alzheimer's had his stains that he could stain his tissue with and look at it under the microscope and see, hey, you know, these light up. Now we've got stains, so to speak, that we can give somebody in their vein, let them rest for about 15 or 20 minutes, take a picture. By that time, those stains, those ligands have latched onto the amyloid in the brain, and you take a picture and it lights up. And there are now actually 3 of those that are commercially available. Florbetapir, approved in 2012, Flutematol with Vizamyl 2013, and Florbetaben, Neurosec 2014. We now, so since we think it all starts with the amyloid, there's been a lot of interest in trying to find out how much of that you might have. But amyloid actually doesn't correlate with cognitive decline as much as tau does, which makes sense if you think of tau as a later phase. But we now also have tau tangle PET ligands, Flortaucipir, just recently developed, that allows us to see how much tau you have, and that is used in research, not commercially available. Then the MRI scans, volumetric analysis, neuroquant, we're going to talk about in a moment. Next slide. So these are the PET ligands, so you can see this wonderful correlation between what we see on that PET scan on the left side and what the pathologist, the microscopist, like Dr. Alzheimer's, sees under the microscope after you die. The more amyloid beta that you have, the more bright spots you have on that amyloid PET, and that corresponds very nicely to how much amyloid you actually have in your brain after death when we check it at autopsy with those original stains. Next slide. So that's the PET scan, looking for the actual amyloid and the tau. And then that third part, the neurodegeneration, is whenever the brain begins to die. And for that, it starts, of course, in the hippocampus, which is the part that that allows you to begin to form new memories. And where in the world is that? Well, you don't necessarily need to know, but on the right panel there, on the right side of the screen where that arrow is, that's pointing to the hippocampus. And so that's the part that we would expect to get smaller first. Next slide. Let's do it. And then that's kind of a good way to see it, because those ventricles, which are the dark spots right in the center, those get bigger as the brain degenerates. So the scan, the volumetric scan, doesn't just look at the size of that structure that gets smaller, it also looks to see whether or not the whole spaces around that structure get bigger, indicating that it used to be larger, used to be normal, it's atrophied, deteriorated, and now there's fluid space, there's fluid taking up that space. Next slide. And this is what one of those scans looks like. And next slide. And you get these very nice charts that show your left and right hippocampus, percent volume of intracranial volume, and the occupancy score, which compares the size of the hippocampus to the rest of the brain. And then the inferior lateral ventricles, the space around it that gets bigger. So what you don't want here is you don't want a really small hippocampus and really large inferior lateral ventricles. That means that the hippocampus used to be bigger. It's gotten smaller. Now you've got that space surrounding it that's empty. This person was normal. The 50% line is of course average, and then there are 2 standard deviations above and below. And so as long as you don't land in one of those areas outside the white region, then you're okay. Next slide. We also have now spinal fluid testing, and the spinal fluid testing is probably more accurate than the PET scan stuff, because it's actually looking at the beta amyloid itself. You don't have to guess about, how many of the plaques have taken up the stain that you gave it. How long have you waited? Did it really work? You can look at spinal fluid, and there we see the low beta amyloid. Why would that be? Well, the beta amyloid, the abnormal beta amyloid, that abnormal form of beta amyloid has been deposited in the brain. And so in the spinal fluid, we actually see less of it. We see high phospho-tau, which is that type of the protein tau that's got that phosphate on it that keeps it from being able to become to stay as a microtubule and makes it fall apart. That indicates actual neuronal loss. And phospho-tau specific to Alzheimer's disease, total tau happens whenever any cell dies, and that's correlates more with any other type of degenerative dementia. So phospho-tau, phosphorylated tau, is the Alzheimer's disease type. Next slide. And we now even have a biomarker. We now even have blood tests, which of course is the holy grail of testing for Alzheimer's disease. There is a blood test called Placebo by company C2N, and I've run several of these in my office. It gives you an amyloid probability score that matches up fairly well with the amyloid PET scan, which has generally been what people have looked at in the clinical trials. It also gives you information about a particular genetic mutation, not one of the early onset ones I talked about earlier, but the ApoE, apolipoprotein E genes that are associated with late onset Alzheimer's disease. Next slide. And so this just shows how far we've advanced in this. If you look at the I guess reddish one on the left, the first curve there, amyloid beta accumulation, that's happening first, and we now can see that with the PET scans, the amyloid PET scans. Synaptic dysfunction, the orange line, the next one, the glucose scans. So it's not taking up glucose, it's not working as well because the amyloid has been deposited. Then the tau mediated neuronal injury, that's the green line. And as that goes up, then you start to go from preclinical into MCI. And then the brain structure, the blue line, the volumetric MRI that we talked about, whether or not there's neurodegeneration, the brain's actually wasting away, and you've gone past your amount of reserve, whatever you were born with or you have from education, that you're able to lose without noticing any cognitive change. You burn through that, and now you're really beginning to have loss of brain power. And the next one, cognition, the purple line, and that's when that neurodegeneration reaches that point beyond your cognitive reserve, where it actually begins to clinically affect your memory, and you notice it. And then the last one, clinical function, all the way to the right, your memory is affected enough that it impacts your daily functioning. Next slide. Treatment. So, next slide. So this, I have a copy of this slide in every exam room. I show it to every patient I see because it is the best conceptual model I can think of for how this works. The red line sloping down is normal natural history, no effect or placebo. It's just progression slowly over time. We now have symptomatic treatment, which is the brown line, the gold line. It gives you a bit of a bump whenever you start to take it, but it doesn't change the slope of the line. So you continue to decline. It helps your memory, but it does nothing to slow the loss of brain cells. Now, at any point in time, you are probably going to benefit from that medicine if you do initially. And so we continue it even though you're getting worse. And people will think as they get towards the end, well, why am I still taking this? Why is my family member still taking this medicine? They're getting worse. Well, they're getting worse because we can't keep them from getting worse, but they're better on the medicine than they would be off. So that arrow second from the right there, the kind of black one, and then the other black one between the red and the brown lines there, that gives you an idea of how much benefit you get early in disease and how much you get late. You're still getting benefit later in disease. And if you stop the medicine there, then they drop from that brown line down to the red line. And I know that for sure because I've tried that in a few patients who were pretty far along. And indeed, they actually got worse when we stopped the medicine. The holy grail, of course, disease modification, deceleration, slow down the course of the disease so that you don't get bad as quickly. And then ideally, disease modification, arrest the green line, keep it from getting any worse than it already is. Obviously, the higher up on that red line you start a medicine, either disease modification or disease arrest, the better off you're going to be. Next slide. So that brings the concept of symptomatic versus disease-modifying therapies. Once brain cells die, they can't be replaced. The meds that and this is an older slide, the current medications, only meds we used to have were symptomatic treatments. And that was the Aricept, which is donepezil, that's backwards. Razidine is the brand, galantamine is the generic, Exelon, the brand name, ribostigmine, the generic. And then Namenda, memantine. Those are, of course, every medicine has two names. So there's a brand and there's a generic, and that's what those are. All they do is they help you manage the symptoms of dementia by helping those dying brain cells function better. The new medications, the big one, disease-modifying things, actually aim to keep the brain cells alive by reducing beta amyloid and tau protein in the brain. Next slide. And this just kind of shows you, this is why we're all so excited here, of course, because it's been quite a while. So forget about the bottom one, 2014, that's not real. There's two classes of medicines, the donepezil, ribostigmine, galantamine, they all act in the same way. Memantine is another one, acts in a different way. That was really the last one approved in 2003. The pharmaceutical companies like to make money, so they combined two old drugs, donepezil and memantine, into one pill. They called it Namzaric, and they got approval for that. So you can take one pill instead of two, but there's not actually any new medicine there. So the exciting thing about the new medicine is it's really the first one we've had since 2003, since the introduction of memantine. Next slide. So this just kind of shows you again conceptually how these symptomatic treatments work. They're called cholinesterase inhibitors. Acetylcholine is just a neurotransmitter coming out of one cell and going up to the next and causing a change to pass a signal. When the first cell releases that acetylcholine, it then gets broken down by acetylcholinesterase, another big word, just something that breaks down that neurotransmitter after it's come out of the first cell. And all of these symptomatic treatments do is they inhibit that enzyme that's breaking down that acetylcholine, that neurotransmitter, so you have more of it. And that's all they're doing. Next slide. The goal, of course, is to stop that process early. So here again, we have that amyloid plaque. And at the left, we see you've got just those small little monomers, those abnormal proteins that were cleaved in the wrong place that are floating around between the cells. Eventually, those aggregate together and they become seeds, filaments, protofibrils, mature fibrils, and eventually they become the plaque. And it's once they get big enough to become the plaque, then that's whenever they're a problem. So just like attacking amyloid is the best way to do it rather than waiting for it to get to tau, so too mopping up these amyloid plaques when they're in their earliest form, their seeds, their small fibrils, even before they precipitate, is going to be a better way to slow the disease, because once it reaches the plaque stage, you can take it away, but that brain cell's really already started to die. Next slide. And this just again shows the spread of tau which is whenever the cell dies, and you release this toxic tau. And the point of this slide is basically that, well, we don't care. Next slide. We can go back to that later if we want to, but right now I want to get to the new medicine. Let's do the next slide. That's the phase 1 trial. Next slide. Aducanumab. Aducanumab is the new medicine that was approved by the FDA on June 7th, I think it was, and it changed everybody's world as the first disease-modifying therapy intended to actually slow the course of the disease. That's a great idea. We're going to mop up that amyloid, and we're going to slow down the progression of the disease. Did it work? So it was approved in a very, very strange way, and I'll try to explain how it was approved. There were 2 concurrently running phase 3 trials called Emerge and Engage. And because the pharmaceutical companies have sunk so much money into this, they do futility analyses during the test to see whether or not the medication they're testing is likely to achieve its endpoint, to do what it's supposed to do. And they did that. And they found in both of these trials in March of 2019 that it didn't look like either one of them were going to work. So rather than pouring more money down the hole, they said, stop the trial. When you stop the trial, stop giving the medicine to the people, you continue collecting data on the people who are already enrolled. And when they looked at more data of the people who had already been enrolled, even though they'd stopped getting the medicine, they found something interesting. October 2019, they changed their interpretation, and they felt that the first trial, Emerge, had a positive outcome, met its primary outcome of slowing the progression of disease. And there were supportive results from the high dose subset in Engage, and ARIAs we'll talk about later. Next slide. So this is the data from the trial. And again, the 2 trials, think of it, remember, Emerge was thought to be positive, Engage was thought to be negative until they looked at that subset of people. So this is Emerge, and you see the placebo on the left, low dose and high dose, and these things, CDR, SB, clinical dementia rating scale, sum of boxes, those are all just different cognitive tests that they give people to see if they're declining. And a higher score on the CDR is bad, a lower score on the MMSE is bad. So the placebo decline, that first column is indicating how much worse the placebo group got. And then if you look over to the right, you see the high dose, and that's the reduction in worsening between placebo and the person who got the medicine. And lo and behold, on their primary endpoint, the CDR sum of boxes, there was a 22% reduction in how quickly those people were getting worse compared to the people who were not getting the medicine. And similar with the MMSE, the ADAS-Cog, and the other measures that they checked. That was at 78 weeks when they had their final data set. Next slide. Engage didn't work out quite so well. Those endpoints failed. So again, placebo on the left, low and high dose, and you look here on high dose for that one, and the first one, CDR sum of boxes, the placebo decline, they got worse by 1.56 points on that test, and the high dose people, instead of getting better, they got a little worse, more worse, if you will, than the people who were in the placebo group. And those other things, those other cognitive tests didn't show anything much more promising either. So it was considered that this study was negative. Next slide. Now, the one thing that both of them did that's very, very clear is that they did reduce amyloid in the brain. So again, you've got what's happening in the brain, you've got the symptoms. What you really care about is the symptoms, right? You don't care how much amyloid's been sucked out of the brain. You want to know if that actually helps and keeps you from losing your memory as quickly. But both of these agents and many other agents before, we know reduce amyloid in the brain. And indeed, in both trials, the red line placebo, and then the low and the high dose, the blue and the green, showing in both trials this dramatic reduction in beta amyloid in the brain with both agents. So if that's the case, then why did one of them improve or slow decline? I don't want to say improve cognition. That's not what they do. They don't improve cognition. They slow the decline. Why did one of them slow the decline and the other one didn't? Next slide. So this is the data side by side of the two trials, looking at the CDR sum of boxes, their primary outcome. And on the left is emerge, the good one. On the right is engage, the bad one that failed. And on the left, on emerge, you see that brown line is the placebo group. They went up on the CDR sum of boxes, which is bad. And the high dose group, the purple, did not go up as much. So that was a positive trial. You look on the right side, engage, their primary outcome. Well, the placebo group, in this case, is at the top. So when they gave them the medicine, these people got worse than the placebo group. So that's not a good thing at all for high dose and low dose. Next slide. So what they did is they then looked at a subgroup of people in engage, the negative trial, and said, if those people have gotten the high dose for long enough, they haven't missed doses, do we then see any change in cognition in them? And that's what they found. So on the left, the amyloid PET, again showing the reduction in amyloid with both agents. CDR sum of boxes on the left, the placebo group going up, the high dose group in emerge not going up as quickly. And then when they looked at people in engage who had gotten enough of the high dose long enough, they also had separation from placebo. And this was at the bottom of the slide there, it says greater than 10 uninterrupted 10 milligram per kilogram dosing intervals at a steady state. So when you do clinical trials, not everybody stays in the trial. People get tired, they don't want to do it, they drop out. But whenever you include the people who stayed in and got the medicine at the right dose for long enough, they felt that engage was a positive trial as well. This is the data that they went to the FDA with. So they didn't go to the FDA with the data of amyloid PET, of the reducing amyloid in the brain. They went to the FDA with this data of, we've got two trials that we think show that reducing the amyloid PET slows cognitive decline. Now, when they got to the FDA, there was a lot of argument about it, and they had their 10-person advisory panel vote in November, and it was 10-0 against approving this drug. They did not feel like the science was good enough. They felt like these trials were not concluded and should have been, and that you can't take two trials that were initially stopped for futility and then look back at the data and reinterpret it and say, hey, it worked after all. The FDA saw it differently. They kind of understood that the subset of data, probably showed some reduction in cognitive decline, but it wasn't good enough for them to approve based on that. So instead, they approved based on an accelerated pathway of lowering the biomarker. So they said, because we know that this drug reduces the amyloid, and reduction in amyloid is thought to, according to this hypothesis, slow cognitive decline, we're going to prove it based on that. And the model for that are cancer drugs. If you find that a drug makes a tumor smaller, they'll approve it, even though you haven't shown that making the tumor smaller actually prolongs life. You'd think it would. If you make a tumor smaller, that's great. That ought to prolong life. You shouldn't need another trial to show that that prolongs life, that it has a clinical benefit. And so that's why they approve it on an accelerated pathway based on the biomarker. The correlation between the amyloid, cognitive function has never been quite that tight. And so we've always felt like they would not approve unless they had two positive phase 3 clinical trials that were completed that showed clinical benefit, not just amyloid lowering. But they felt, based on the data, that it was appropriate to approve this drug based on the reduction in amyloid. Next slide. So the summary of the results following termination based on the futility analysis, the larger data set showed that emerge high-dose aducanumab reduced the clinical decline by their primary and secondary endpoints. And the final result, engage, aducanumab did not reduce decline. But in a post hoc analysis of ENGAGE, data from a subset of patients exposed to a high dose for long enough supported the positive findings of EMERGE. And of course, it showed an effect on the biomarkers. It reduced the amyloid. And so it was approved on June 7th. And that trial, both of those trials, EMERGE and ENGAGE, are actually continuing now in a trial called EMBARK, where people who were in both of those trials are now getting the medicine, and they're following their cognitive function. And adverse event, yeah, I'm about to finish up, so if there are any questions, I'll be ready for them. And the most common adverse events, ARIA, E, and headache. Next slide. So ARIA, E, and H. ARIA, Alzheimer's related imaging abnormalities. And there's two kinds. There's edema, which is swelling, and there's H, which is bleeding. And this is a patient from Georgetown who was in one of the trials. And in February 2014, their brain was okay. In June of 2014, they had ARIA E. They had swelling, edema in that part of the brain that you could see on the MRI. They stopped the drug, and by August 2014, it had gone away. So this side effect is usually asymptomatic, and it usually gets better. So, so we have a very clear series of MRIs that we check for asymptomatic ARIA. And if we find on an MRI that you're developing this stuff, even though you have no symptoms, we hold the medicine, give a chance for that side effect to clear in the brain, and then generally you can restart. Next slide. And so other anti-amyloid meds pending, the FDA has kind of opened a Pandora's box by approving a medicine based on its ability to clear amyloid, because there are a lot of other medicines that do. The Trailblazer trial, donanemab, very similar to aducanumab, currently in phase 3, gathering clinical data, but we already know it lowers amyloid. So why wait to see if it actually improves clinical outcome? That's not required anymore. So they went ahead and applied. Their applications in with the FDA right now saying, approve us too, just like you did aducanumab, regardless of whether it improves clinical function. And I've joked with the guys at Georgetown, what if it gets approved based on the fact that it lowers amyloid in the brain, and then they finish their phase 3 trial and find that that had no effect on cognition, didn't slow cognitive decline, then they've got a problem. Next slide. So, doctor, would you take it? And I say yes, and I say why? Because there's more evidence of benefit with aducanumab than there is for the dozens of other supplements that people already take. And it is a true never-ending litany of things that people will sell you to improve your thinking. Prevagen, seriflunomide, turmeric, serine, omega-3 fatty acids. The list just goes on and on. And there's no good evidence that any of those things work. In fact, the FDA, the Attorney General of New York has got a case against Prevagen right now for false advertising. Next slide. The last point here, the last slide, just to remember about those supplements, lack of evidence for benefit does not equal benefit, does not equal evidence of no benefit. So you might get benefit from your ashwagandha, but without doing a trial, you don't know for sure. If you do the trial and it's clear it didn't work, then you know it doesn't work. So you can take all the supplements you want, but don't forget about an FDA-approved drug that's been extensively studied, is now approved, and we now can administer, that we have some evidence that it works, as opposed to a supplement that has no evidence that it works. Next slide. And that's it. I'm going to open it to questions for anybody now. That's a mouthful.
All right. Well, thank you so much, Dr. Bicksel, for just jam-packing all that good information into the hour that you had. We do have a question on the floor. It says, is there a test to see if you have a rare genetic mutation that guarantees that you will get Alzheimer's?
Mm-hmm. Yes, there are genetic tests for that. They're commercially available. It's so very rare, we really don't do it. And in addition, it tends to run in families. So if you had this genetic mutation, you'd probably know it because this happened to your parents. the chance of it occurring spontaneously without it running in the family is very, very slim.
Okay, thank you so much.
Mhm.
The next question is, are there any drugs being studied for those with moderate AD?
That's a big question because this drug is only approved for people with mild cognitive impairment or early Alzheimer's. And there's not a lot being studied for moderate. And the reason is that these ARIAs, these side effects that we see, happens due to removing the amyloid from the brain. You can get swelling, you can get bleeding. If you're further along in disease, then you've probably got more amyloid in your brain. Taking that out is going to increase the chance you're going to have a dangerous side effect. And so there generally are not a lot of trials for people with moderate disease.
Thank you so much. The next question is, who is eligible for aducanumab? How do you become eligible?
So this is as I wanted to flip through my own slides because I was feverishly at the end trying to put up the algorithm that I use to determine eligibility. The FDA did not give us a lot of guidance. In fact, they changed their guidance. They initially just approved it for everybody, then they finally limited it to the people like the ones in the trial, early AD and positive biomarkers. There was a paper that came out with appropriate use recommendations, and that basically is age below 85, because that was as high as they were studied in the trial. Mild cognitive impairment or early Alzheimer's, some biomarker test showing that you've got plaque amyloid as the cause of your memory loss. An MRA within the last year with no history of strokes or bleeds, intracranial hemorrhage, no history of cancer within the last 5 years. And those are really the big ones. And so if you have to be able to get an MRI, of course. If you can't get an MRI, then you can't have the medicine because we have to use that to follow for side effects. And that's pretty much it. It follows the same things as the trial, which is basically, early disease, positive biomarkers, and no other major medical problems that would make us worry that giving you the medicine is going to be a problem.
Okay, thank you for that. The next question is the medication that you are discussing available for folks not in studies? Is there a usefulness in moderate AD?
For the aducanumab, again, not indicated in moderate AD. And of course, as with everything else, we can think that it's dangerous in people with moderate disease because it pulls the amyloid out and gives us side effects. We don't know that for sure. It'll probably be tested in moderate at some point just to see if that actually happens. But right now, we're just following the inclusion criteria from the clinical trials that the drug was approved based upon.
Thank you so much. The next question is, do you have do any of the treatments affect vascular dementia?
No, they wouldn't affect the disease modifying aducanumab would not affect vascular dementia. There's a large overlap between vascular dementia and Alzheimer's disease. So if you've got the plaques, then it might help that, but it wouldn't help pure vascular dementia.
Thank you. The next question is, what is the cost of the drugs resulting from Engage and Emerge?
So the cost is $56,000 a year for the medication itself. It's weight-based, and the dose goes up over the first 6 months, starting at 1 milligram per kilogram and then inching up slowly to 10 milligrams per kilogram. For the 1 milligram per kilogram, the cost is about $1,000. Right now, Medicare is really grappling with this. They don't know what to do. Within the next 6 to 12 months, they're going to have a national coverage determination where they're going to tell us we will pay for it based on this, this, and this. Right now, it's up to the local Medicare administrators as to whether or not they would cover it. So I'm only giving it in people who understand that it may not be covered by their insurance and consequently are willing to pay for it up front. And once we put it through insurance, if we're reimbursed, then we give them their money back. But But at this point, and that's going to go away, you know, I mean, we're going to get determinations and we're not going to have to do that anymore. But at this point, so very early on in the drug, everyone's figuring out how it's going to be paid for, because obviously, you know, huge cost, millions of people with Alzheimer's disease who are going to want this drug. In fact, in some ways, the controversy over the approval of this drug has been a blessing, because if this had come out as a silver bullet, everybody in the world would have wanted it. There's not enough infusion chairs in America for all the people with Alzheimer's, with all the different stages, to get it. So in some ways, it's kind of slowed the introduction and allowed us to kind of get ready for it, including the insurance approval.
Thank you. You touched on the next question about Medicaid covering the cost, and you kind of went through that. Why do some family members get the disease and others don't?
So there's that one gene, the ApoE4, that's associated with late onset Alzheimer's. And if you have that from one of your parents, you have about a 20% higher chance of getting it. If you have 2 copies, about an 80% chance higher of getting it. But that's also a very common gene. So to answer the question more directly, some people get it because their parent had this thing that causes it late in life. Other people, they don't have that gene, they just get it. It's a pure spontaneous event, and we don't know. Wish I had a better, I don't know the answer to that. I don't think anybody does.
All right, thank you. Are there any foods that we can avoid from mild to severe dementia, like coffee, etc.?
No, not necessarily. The Mediterranean diet, you know, everybody wants to know about lifestyle changes and diet changes. Just a good Mediterranean diet is useful. Exercise, physical activity is probably the biggest non-medical, non-medicinal thing that you can do. Being cognitively active is important. You can spend a lot of money on brain games, but that doesn't generalize. You get good at Sudoku, but still can't find your keys. So those brain games that people try to sell you, they don't actually slow the decline, but staying generally cognitively engaged in something that interests you and learning something new is the best non-medicinal thing that you can do.
Okay, I know we have about 3 more minutes and we have a few more questions. Let's see if we can get through them. The next one is the severity of headaches that we're talking about in regards to the new medicine, aducanumab. How much brain bleed and brain swelling is caused by this? And how can a caregiver tell if there is a brain bleed or brain swelling?
Yeah, I think I might have skipped over that slide. About 30% of the people who get this medicine are going to have one of those side effects. And just because it generally gets better doesn't mean that it's entirely benign. You have a higher chance of getting one of these side effects if you have one of those ApoE4 genes I talked about. But otherwise, there's a pretty high chance. So we have to watch very closely. And the way we do that is with an MRI, you know, soon after the first infusion, you know, and several during the first 6 months. And then how do you know if they've got it? You might not, they might have no symptoms at all, but the biggest potential things you'd notice would be persistent headache, maybe an increase in confusion. I think those are the big ones.
Okay, we have another question. One of the participants is saying that their 98-year-old grandmother has dementia, noticing the right hand is closing up. They can pull the fingers out, but it curls back up. Is this a part of dementia? And then they said they have an appointment with the rheumatologist next week, but they wanted to ask about that.
Yeah, it's not typical for dementia. I mean, it sounds more like a stroke or some type of vascular issue in the brain. Eventually, people with Alzheimer's will have motor manifestations, but that's generally whole body stiffness, completely mute, no interaction, eventually trouble swallowing, and starting to get infections from aspiration pneumonia, not even being able to protect their airway. It's not something focal like that. That sounds much more like stroke. Okay,
thank you so much. To be eligible for the new drug, do you see a neurologist? What is the process?
Yeah, you'd have to start with a neurologist. Not every neurologist is doing it. And as it catches on, it's going to be harder and harder to do. the big health systems are having to get it on their formularies. So in Nova and Georgetown, they can't necessarily do it because their pharmacies can't get it. You can order it directly, which is what I've done. But yeah, you start with your primary doctor, then a neurologist, and then hopefully a dementia specialist, though, as I say, there are not nearly enough of this in the world to handle all the people who would want this.
Thank you so much. I think this is actually the last question that we will have because we're at time. So thank you so much, Dr. Bicksel, for all of your knowledge and just sharing your experiences and your time today. We appreciate you.
Thank you for having me. Enjoyed it.
All right, and I'd also like to extend my thanks to Dr. Bicksel for being here, sharing all this great information with us this morning, and for everyone who's listening in and typing in all of these really important questions. So Marquita and I will see if there's anything that we might also be able to respond to that we didn't have time for. We are now going to take a 5-minute break until 10:20, and then we will move forward with our second session this morning, which will be about tips when you're managing someone else's money. So we'll see you all in about 5 minutes. Well, hello everyone. My goodness, those 5 minutes flew right by. So thank you for being back with us for our Caregiver Bootcamp this morning and our second presentation. So our next presentation is going to be about managing someone else's money, tips when accepting fiduciary responsibility. And before I introduce our speaker, we have a couple of poll questions that we want to put out for everyone to learn a little bit more about you and to make this presentation as effective as possible. So I'm going to launch our first poll question. So you should see this up on your screen. Are you currently managing someone else's money? Maybe a well spouse for an ill spouse, an adult child, family member, friend, or someone else. And your choices are pretty straightforward. Yes or no. So go ahead and type those in. Great. I see about a third of you have entered in your responses. All right, keep them coming. Oh, Tom, you're going to be pretty interested in seeing the results. All right, keep it coming, everybody. About half of you have put in your votes. Are you currently managing someone else's money? All right, I'm just going to give you about 5 more seconds and I'll close this poll. I know you're all running back to your computers after that 5-minute break. All right, 3, 2, 1. All right, so here are the responses from this poll. It looks like 58% of you are currently managing someone else's money. 42% of you are not yet. Okay, so we're swinging just a little bit towards the yeses. And I'm going to put up a second poll question. When do you plan to manage someone else's money? You're currently managing someone else's money? You think in the next 12 months you might be managing someone else's money? Maybe in the next 2 to 5 years, or you have no plans to manage someone else's money. All right, so go ahead and enter your selections. Oh, you guys are right on the ball. We got more than half of you who've already voted. Keep it coming. When do you plan to manage someone else's money? All right, I'll give you a few more seconds here. All right, about 3/4 of you have voted. Great. Okay, I'm going to close the poll. Share the results. 58% of you are currently managing someone else's money. 21% think you will in the next year. Only 8% are anticipating over the next 2 to 5 years. And 13% of you are like, no way, no plans to manage someone else's money. All right, so now I'd like to introduce our speaker for session 2, Tom West. Tom is a senior partner at Signature Estate and Investment Advisors. He's also the founder of the Life Care Affordability Plan, and he is super active in the community, especially in support of older adults, currently serving on the board of directors for the Jewish Council for the Aging, vice chair for the corporate board of Goodwin House Incorporated, and he's previously served on the boards of Insight Memory Care Center, of which we are so grateful for his leadership, and he's previously served on the board of the National Capital Chapter of the Alzheimer's Association. So Tom is a wealth of information, great resource to all of us who are in support of older adults and those living with dementia. And now, without further ado, I'm going to turn it over to Tom to share his screen and take us through this next hour together.
Good morning, Lindsay, and it's great to be back. Just confirming, managing somebody else's money is up on the screen. Slides work?
Yep, we see it.
All right,
Thanks.
fantastic. Good morning, everybody. It's great to be back working with Insight again. I did a quick calculation and prep for this, and I think this is my 16th or 17th year of in some way, shape, or form being part of the Insight community, and I always enjoy coming back, so I appreciate the opportunity to share a few ideas this morning. When everybody looked at the poll and we were thinking about, the 87% of those of us in the audience that are either currently managing somebody else's money or in a reasonable period of time anticipate a pretty decent likelihood of managing somebody else's money, I think this presentation is really built for you. And for the 13% that, I'm not planning on managing somebody else's money, this might be for you too, because part of what we did when we built this program was try to come up with a range of topics that would appeal both to professionals, like attorneys that are serving as conservators and reporting to different counties about how exactly they're managing or stewarding somebody else's money, all the way to somebody that really doesn't have a whole lot of experience or comfort level in terms of managing portfolios and cash flows. This presentation is really sort of built for everybody. And I'm going to be trying to move at pace so we can leave plenty of time for questions at the end. But really the perspective that I wanted to start with, and take a look at the title with me, Tips when Accepting Fiduciary Responsibility. And a lot of us have heard this phrase fiduciary. And I wanted to start with the idea of what is it that fiduciary really means? Because when we might find ourselves in the position of having to make decisions about property and money for somebody else, and we're told a lot about needing to have a fiduciary standard of care, what is it that we're really talking about? And how do you go ahead, how do you measure that? And basically, what is a fiduciary? There's 4 basic ways to think about being a fiduciary. The first one, and this is sort of 90% of the definition in my mind, is somebody that acts only in the best interest of another. And that's the standard of care that is sort of universally translatable to everybody, regardless of experience. Needing to manage money and or property very carefully, making sure that you're keeping regular attention on it, keeping money and or property separate from yours. We'll talk about that, particularly for fiduciaries or financial decision makers that are managing money for a parent or for somebody that they don't share accounts with. This keeping money and property separate is going to be something that's pretty important. And then this last bit, keep good records. Those are all basically the general tenets of being a fiduciary. And we'll go deeper into what that means and some practical tips about what are some different ways to make some effective decisions in the face of diminished capacity, in the face of some cognitive impairment, both with how do you maintain your ability to make good choices with a lot of ambiguity, but then some technical things too, how to think about portfolios and taxes and whatnot. And that's really going to be the range of the comments that we cover today. There are different kinds of fiduciaries. So for example, I work in a wealth management firm. My team does a lot of financial planning for families that are struck with long-term care expenses or planning ahead. And we serve as fiduciaries where we have a standard of care with our clients. We're acting in the best interest. But you too, as a manager of somebody else's money, could be in the exact same boat that I'm in. Different kinds of fiduciaries can be named because you might be identified in a durable power of attorney. You might be identified as a trustee or a successor trustee in a trust document to make decisions about property. Representative payees for Social Security or Veterans Affairs is technically another kind of fiduciaries. Or sometimes, in the absence of legal documents, sometimes people get named by a court to serve as guardians or conservatives for somebody that can't make decisions for themselves. And that too has a fiduciary standard. Each of these different 4 have some slightly different rules about how you're supposed to be performing your role as a fiduciary. Let's get into a little bit more detail. If you're thinking particularly about a power of attorney or a trust, how is it that you start with considering acting in the best interest of somebody else when you're managing somebody's money? I would implore you to start with the easy thing, which is read the actual document that might name you as the fiduciary, as the person who's responsible for making decisions about money. Sometimes there's some instructions or there's some disclosures in the legal document that's put together that might be critical in you understanding what exactly you're supposed to be doing or how you have to take responsibility for somebody's portfolio or investments or whatnot. I always start with just read the document and make sure you're familiar with it. And if there's questions about it, please reach out for some legal advice to make sure that you understand what those responsibilities would be. Because part of what happens in a lot of these documents is understanding when it becomes effective. Does it become effective immediately after the document was signed? Does it become effective only when somebody is showing some kinds of cognitive impairment? How are those things measured? What's basically the threshold that your responsibility really starts? That's something sometimes it's really in the document itself. Avoiding conflicts of interest, making sure that you're not self-serving in any particular way. That's obviously a particularly important component of being a fiduciary. And this is we get a lot of questions about, if there are plans that are already in place about giving away money or property or charity or things like that. Avoid, as a general rule of thumb, making changes to plans that are already in place unless there's a material reason to do so. But just as the same as in conflict of interest, it's probably something that you want to think twice about before starting new types of things where you might be gifting property away. And this last piece, don't pay yourself out of the individual's portfolio or money unless specific permission is granted in the document or in however you get the authority to be making decisions for somebody else. In this piece, I'm a big fan of trying to keep things simple. And one way to keep things simple is to write everything down. When in doubt, get it on a piece of paper. And I always start with a good way to manage money or property carefully is list everything out. Where's the property? Where are the debts? Protecting property is also, remember, an important element of managing somebody else's money. If there's a house, if there's another piece of real estate, if there's a business, it might be your responsibility to keep that property up. So making sure that it's not neglected. There are also some practical steps that you're expected to take about your investments. Make sure that you're investing carefully. I'll go into some more detail with that. And also, it's your responsibility for paying bills, for managing expenses. And it's also your responsibility a lot of times that if you are named in a document like a power of attorney or in a trust to be assuming the responsibility of stewarding somebody else's money, it's your responsibility to go to the different financial institutions to make sure that that document gets accepted. Sometimes different banks, different investment companies have their own protocols and processes in order to accept somebody's durable power of attorney or trust authorization. And it's your responsibility to make sure that those kinds of things are honored. And this piece here, it seems pretty straightforward, but it's worth mentioning. Keep money and property separate from yours. If you are a spouse that's managing an ill spouse's money, I'm not really speaking to you. If you've got joint accounts with a husband or a wife and you're managing that kind of wealth for somebody else, I'm not really speaking to that because I'm mostly speaking about professionals or adult children or friends. You want to make sure that you're keeping the property that you're managing separate and making sure that it's titled appropriately. There's also a practical tip. Learn how to sign as a power of attorney or learn how to sign as a trustee. Sometimes when you're giving written authorizations on applications or distribution instructions or things like that, you don't just want to scribble your name. The document and the entity, the financial services entity, is going to want you to write out, Tom West, power of attorney for spouse Beth West, Tom West, trustee for the Beth West Trust, etc. Those kinds of things are small little details, but really make sure that the authorization that you're given in written form is accepted and legal. This is another piece that it just bears mentioning. You think it's common sense, but keep good records. Sometimes with the challenges of managing wealth and managing healthcare in a time of diminished capacity, people can forget just to keep good records. Write things down. Keep a paper trail of money that's coming in, money that's going out, and as much labeling as you can do in terms of what those things might be. That'll help in case there's anybody that comes back, a family member, a court, something like that, that wants to audit or second guess any of the decisions you've made. Keeping a good paper trail is a way to keep you and the individual that might have some diminished capacity protected. With all of that being said, I also want to sort of step back and, well, that was sort of some pro forma stuff, Tom, but as caregivers who might be managing money for somebody else, how is it that you really make decisions? How is it that you are trying to pay attention to managing a portfolio or cash flow, but I'm also trying to take care of myself. I'm also trying to make sure that the person that I'm taking care of is safe and doesn't feel vulnerable, and with diminished capacity is as comfortable in their care as possible. with all of these different sort of challenges to just people's bandwidth, how do you really practically make decisions? And let me start with, the real theme of our presentation this morning, which is the way you sort of work your way through this with all of the challenges is to develop a process. And think of a process like you just go through the same steps on a regular basis. And this quote from Dwight Eisenhower, I think, is important, because with all of the uncertainties about dementia and knowing that things can change, it's always appropriate to remember that, the plans that we make are nothing but planning. Planning is a process, is everything. And what we're going to be talking about for a good part of our discussion today is, what does this planning process really look like? What's repeatable? How can I do things where I'm managing somebody else's money in small, bite-sized, manageable pieces? But how also, if you're a professional or if you're somebody that's doing this regularly, what's a good refresher on best practices to make sure that I'm meeting the highest standard of care that I possibly can? And what the slide really says is, how do you gain control of finances after the death of an individual, a disability or an illness? That's what we're speaking about today with cognitive impairment. But it's the same as developing a process after a profound loss or a profound windfall. How do you reset the way that you think about money, or the way that you think about somebody else's money in the face of all of the uncertainty with something like a cognitive impairment? There are challenges in decision making, and let's just, let's boil down a few of the big ones. How is it that I'm supposed to be managing money when I don't know how long somebody's going to live? How is it that I make decisions about the short term, the medium term, and the long term of finances when I'm not exactly sure how much help somebody needs, and how much help the things that my family might be able to provide, or how much help are things that I might have to pay for? When I was thinking of Dr. Bicksel's presentation talking about a new angle of the potential cost out of pocket of medication on top of what could be significant costs for actually care in the home or in a separate facility or community. How do you make decisions about your money when you're not exactly sure how long all those things might last or when they might start? And those are the two biggest challenges that I see about people getting started in developing a good process to make decisions about managing their own money or about managing somebody else's money. And look at this last bullet, because I think it's important. There's a tendency in all of us, when faced with a lot of uncertainty, to procrastinate and to not do anything until more information or better information presents itself. Because if I just had a little bit more information about what happens next, if I had just had a little bit more feeling of accuracy about expectations about what might be down the road, people sometimes feel like that could be enough to empower them to take new responsibilities or to make some decisions. But part of the reality of dementia and cognitive impairment is it's pretty unlikely that at any particular point in time, there's going to be so much certainty about what might happen next that people feel like they can move forward with 100% confidence in a lot of these challenging decisions. So what I'm trying to say is, another unfortunate reality of managing somebody else's money when you're dealing with something like cognitive impairment is you probably won't have absolute certainty about how long somebody's going to live or how much help they're going to need when it comes time to actually make good decisions. And procrastination, waiting for better information, while it's certainly sympathetic, it also sometimes can be a self-fulfilling prophecy. And by not taking action, although it's sympathetic, sometimes can paint people into a corner, and you might be getting worse outcomes if you're thinking that way. And that's part of the reason that the process that I'm going to be talking about is so important. New roles of when people are assuming new responsibilities of sometimes managing somebody else's health or managing somebody else's finances. Just because a piece of paper says that I might be the trustee or the power of attorney for hypothetically my mom that might need some additional assistance, it might not always be that easy. Does my family, does my mom in my example accept the authority that I've got in this document? We certainly know that with cognitive impairment, sometimes people might not be fully aware of their particular predicament or the way that their decision making might be compromised. So we still have to navigate that. How is it that you set realistic expectations about what's happening right now and what might be coming down the road? And it's also worth pointing out, there's just an additional amount of stress associated with managing somebody else's money on top of managing somebody else's care and trying to take care of yourself. So certainly we appreciate all that. When you consider a little bit my next bullet here, delegating and asking for help, I think this is a pretty big challenge with managing somebody else's money. Delegation, a lot of times when you're delegating, you're assigning responsibility to somebody else to sort of maybe give assistance somewhere in here. For a lot of individuals, for a lot of families, it sometimes is experienced as a loss of control. And that the reaction to feeling like managing somebody else's money is a loss of control, sometimes in and of itself can inhibit good decision making. And it's useful just to call attention to that and make sure that that's sort of identified as a circumstance that you have to work through. In this last piece here, asking for help, I find this to be one of the last very predictable challenges in making good decisions about managing somebody else's money, because sometimes people don't know exactly where to start asking for help, and they're not exactly sure, if I start asking for help, am I losing some control? We'll talk about a good process in the next slide or two in terms of getting that started. A lot of times when families and individuals are charged with managing somebody else's money, there's questions that we get about, look, there's a lot of changes that our house, that our family is dealing with. What decisions do we really need to make right now? And what decisions can we put off? And I think a good place to start is some guidance about that. We always want to start with taking small steps. And when you're thinking about decisions that have to be taken care of right now, it's also useful to look around and scan, your world, your support group, places like Insight, and try to identify a qualified guide. And I really like the way that the boot camp today is sort of set up with guides from a professional standpoint on things like today, what I'm talking to you about with managing somebody else's money, or the research side of things that Dr. Bicksel talked about, but also some caregivers that have walked the path that you might be on right now before you. Identifying a qualified guide is a huge place to start in terms of knowing how to ask for help and how to take charge of different pieces. When you're also thinking about decisions that you have to make, well, list out your responsibilities specifically and make sure that you understand when you need to act on them. I also always coach people to listen, be patient with yourself. This a lot of times wasn't somebody's plan on what they were doing. So, giving yourself a break and not demanding perfection in your decision making right for the jump is important. But do make decisions, even if they're conservative decisions. I always like to coach families that are managing money for other folks to consider what's time sensitive as a place to start. And I sometimes do this for clients, sometimes clients do this on their own. Make a list of time sensitive things that have to happen and when they specifically have to happen. And a good place to start would be making sure that you know when your taxes need to be not just filed, but when all the information needs to be put together with the W-2s and the 1099s. And if you're having somebody else do your taxes for you, when do you need to get all that stuff in? It's a pretty typical circumstance that when we work with clients, sometimes getting the tax filing process sort of set up and running smoothly, that's one of the first things that we sort of build around with important dates to act on. Also, if there are mandatory payments, things that sort of are going out of the checking account that go regularly, think of things like mortgages, rent, car payments, but also think of things like property taxes. Are there particular periods of time that you can find on a calendar that you could put a note on the calendar that says, it's now time to make sure that we pay the whatever it ends up being. And then the last one that I would want to remind you, for those that are in their 70s or higher, required minimum distributions from retirement accounts, whether they're IRAs or 401ks or thrift savings or whatnot. Remember that after 71, the required minimum distribution is an amount that the IRS asks you and mandates that you take out of your accounts every single year. And if you don't take it out by the end of the year, December 31st, sometimes there can be penalties that are assessed by not taking money out. So be sure that you pay attention to your required minimum distributions as well as important dates to act on. And it's this next section that I think is something that's we start out with a lot of conversations with families that need some guidance, which is, listen, I understand everything that you're saying, but I really simply just don't know a place to start. You know, if you don't know what decision to make or when to make it, how is it that you just get the ball rolling? Like with all of the different things that's going on with me as a caregiver, as a family member, as somebody that's trying to take care of myself, I know I'm managing somebody else's money, but where is it that I start? And I hope that this part of the presentation is practical, is useful, and for those that even are professional grade fiduciaries, it's just a good refresher of best steps. But the answer is begin a decision-making process that by itself meets a fiduciary standard. And let me show you what that process really looks like. In a lot of decision-making in different disciplines, whether it's financial planning or law or medicine, generally speaking, there is a consensus about how good decisions are made. And when you think about, you know, meeting a fiduciary standard, like if a court is going to be looking at how well somebody is actually making decisions for somebody else, whether it's healthcare or whether it's in finances, this decision-making process is one that, generally speaking, everybody's got some consensus, sort of the best way to sort of move through executing decisions in the time of a lot of uncertainty. And here's basically the steps, and I'll go through these in more detail. Make sure before you do anything that you start at 12 o'clock, which is organize as much information as you possibly can. Don't start making decisions or trying to zero in on specific choices until you have a pretty good idea of what all of your different circumstances are. And more narrowly, when we're talking about managing somebody else's money, don't jump into a decision until you have a full understanding and a full organization of all of the different moving parts. We'll talk a little bit about evaluating all your different choices and how to identify the best one to move forward. Formalizing is basically deciding which choice that you're going to go through, you're going to execute on, and making sure that you understand what the steps are. A lot of times with executing a particular decision, we have to identify that as its own step. And then monitoring for effectiveness is going to be the last piece, and I'll put all these together for you. But broadly speaking, when people are managing other people's money, if they follow this 5-step process regularly, what we found from a professional standpoint or looking over the shoulder of family members that might be doing this for themselves, they get better outcomes because they're not skipping ahead and they're not going into a situation where they might not have all the information that they need. So this is a little bit redundant from a previous page, but get organized. Well, what exactly does that mean? I like, when we're talking about managing somebody else's money, I think what getting organized means is get a balance sheet together. What a balance sheet really is, it's something that's in writing that basically says, here's where all my money is. And these are all of the debts, if I have any, mortgages or credit cards or whatnot that I owe. Put that all in one place. Just organizing that by itself sometimes gets good momentum to start a good decision-making process, because you're actually not being forced to make any decisions in the organization process. You're just self-diagnosing, or you're putting the information together that you might be able to show a professional to be able to give better guidance. You know, organizing cash flow, what you're spending versus what you're earning. And I also, this two next bullets, I think sometimes are critical. Identify things that can change. When we're thinking of diminished capacity, when we're thinking of dementia, things like the cost of care, those are things that can change. So we want to keep a special eye on those categories in a cash flow that can change. And obviously the opposite of that's true. What are things that really aren't going to change? They might be in a little bit of a separate category. Maybe there's a pension that as long as somebody's alive, they're going to get paid a pretty regular amount, or like Social Security. That can help in terms of when you're looking at your own financial statements, orient yourself pretty quickly on the areas that you got to pay attention to, because it's going to probably be the stuff that might change. It's going to be the thing that's going to merit your regular attention. And also, when you're doing a balance sheet, when you're doing a cash flow statement, identify areas that might be simplified, identify areas that might be consolidated, because we get a lot of questions about risk, for example, portfolio risk. And the way that I always start an answer about risk is the same way that I start an answer about complexity or unnecessary complications. Risk and complexity are not by themselves bad things. A good attitude for you to have as a fiduciary is you just want to make sure that you, as the manager of wealth, are getting something out of the extra risk, or getting something out of the complexity. If there's a reason, a good reason, that money might be in a whole bunch of different places, that might be a good reason to keep it there. But if not, it's probably better to simplify, to consolidate, to make things a little bit easier to manage. The same thing with portfolio risk. If you've got very risky investments in your portfolio, that's not a bad thing. But you do want to make sure that you have a good understanding that you're getting paid in terms of a good rate of return for taking that risk, and not taking risks that you shouldn't be taking. And I'll talk about portfolio management a little bit more in the next slide or two. But getting organized is a place to start. Think of the medical process of you want a good diagnosis first before you jump into prescriptions. This next piece, think about evaluating all your different choices. And when you're starting with a disability or illness like a cognitive impairment, it's usually things like, listen, these are my different options for housing. Maybe we want to stay at home as long as possible, but if that doesn't work, we might want to think of what other places outside of the home might make some sense. Are there programs like Insight's Memory Care Center that might be somewhere in between spending all of your time in your home or making a transition to a dementia-focused facility? Those kinds of things, in terms of identifying those different choices, being able to figure out, not just from a health standpoint, but from a financial standpoint, what are the costs and how might you get a running start in terms of being able to set yourself up to best handle those. Formalizing a plan, this is where we start anticipating outcomes. I always, when you say dependent on a goal, it's also useful, everybody in the audience, to recognize that goals and priorities change. Just because you had a handful of things that might not have been about money, but involve money, before a period of care or before a diagnosis of dementia, that doesn't mean those priorities might not change. And I'll give you an example. It's a pretty normal conversation to have, an individual that might need some help with cognitive impairment, that the most important thing is to stay home for as absolutely long as possible. But then circumstances might change, and maybe something like memory care at places like Insight, maybe being able to have that kind of support is the new most important thing. Sometimes priorities change after that. Maybe family members or spouses want to be together, and if a change for a home setting needs to transition, maybe being together is the next most important thing, and so on and so forth. Be aware that the goals and the priorities change, and then the choices that you've got might also change along with them. But I always like to ask this question, with my audience, which is, how do you set priorities in terms of knowing what to do, or how do you set priorities about figuring out what the most important things are? And this is a little bit, hidden in my fourth bullet here, and the phrase consequence of failure is a good concept. I'd invite everybody that's managing money for somebody else or managing the care for somebody else to think about what's the consequence of a plan failing. Does it mean that somebody might not be safe? Does it mean that we might have some other elements of my financial security taken away if we don't go a particular route? I always have a dialogue with my professional clients, my personal clients, about what's the consequence of failure? What are the things that we need to make sure that we get right? And the ones that have the highest consequence of failure, that we just can't afford the downside, whether it's a financial downside, a personal downside, or a healthcare downside, those are probably the ones that should go to the top of the most important set of decisions. That's some good ways to think about it. And I have this next slide here, executing a plan. It shouldn't surprise you that sometimes families, or those that are charged with managing somebody else's money, can go through all of these steps and then just not pull the trigger on a decision that really needs to be made. They get themselves completely organized, they identify all of their choices, they make an idea that this is going to be the choice that's the best for me, but then there's a space where the progress stops. And I think that it's really important to identify executing on that particular decision, sometimes consolidating funds, sometimes thinking about taxes, sometimes making a placement outside of the home. It's understandable, back to this idea of procrastination, that people might not execute on plans. It's really important to identify that important part of the process is decisions that need to be made. You actually got to make the decision and move forward. And I have a few bullets up here a little bit more narrowly because I'm expecting some questions about portfolios and taxes. How is it that we think a little bit about monies that we've got? A good way to think about it is, whatever your makeup of different investment accounts or bank accounts or whatnot, those might have been appropriate for a previous chapter in your life. But in my first bullet, does that previous portfolio allocation still work? Is it still appropriate for me and my family, or the individual that I'm managing money for? Is it still appropriate for them right there where they are? Same thing with cash flow. Is the rate of withdrawals that we're taking out of the different accounts, does that need to change? Do I need to change things around? And this last one, liquid reserves, I think this is important. The more your cash flow can change, the more you might have to incur much larger expenses to pay for care. I think that it's sometimes an overlooked area is how much cash on hand is appropriate. And there's a balance. You want to have, I think, at least 6 to 12 months worth of cash on hand for expenses that you can think might be coming, like worst case scenario might be coming. But it's also important to figure sometimes people, panic and they put too much money in liquid reserves and they don't have enough sort of working for you for periods of time longer than 2 or 3 years down the road. I always like to sort of close this part up with, what's the new job of the money? And you go back to your priorities. The job of the money is to keep my loved ones supported, staying at home as long as possible, no matter what. And if that doesn't work, maybe it's thinking about affording care, whether it's places like Insight or another facility, or the next potential job of money might be moving somewhere together, and all of that entails. But the new job of the money should be changing with the new circumstances that are around the most important thing with taking care of the individual that you're helping out. And this executing plan, I also like to talk about, just for a minute, tax consequences. With all of the complications that we've got about the intersection of family and healthcare and finances, the idea of just bringing up taxes, I don't want to omit that. Tax consequences of making some of these changes, I just want to remind everybody that, they still matter. They still are material in good decision making. And a lot of times families make decisions about portfolios or make decisions about settings of care and rearrange things in their portfolios that can have big tax implications, and they have some unintended consequences. I think it's real important to make sure that before you do anything, you've got a really good understanding of what is the best way to execute on some of your decisions as it relates to taxes. And that's part of the effort of just writing everything down and evaluating all of your different choices. Let the fiduciary plan itself be your guide, constantly organizing, identifying choices, executing plans, and so on. And then this last piece, I had a client of mine express to me that, after she made some financial decisions, there was so much relief and letting go of some stress that she finally made some appropriate decisions that she just didn't want to look at it anymore. You know, it's I did this one thing and whew, and now I'm done. I do think that there's also a reality of, you know, you got to keep monitoring the situation. Just because you made your first choice doesn't mean that you're not constantly responsible for reorienting. And sometimes it's appropriate to delegate some of these things to professionals as needed, but I would invite you to commit to a timeline to reorganize yourself and to start the process again. Make sure that you start again at the idea of getting all your information in order, figuring out what your sets of choices are, formalizing your plan, executing, and so on. But don't let go of the decision-making rudder. And this last piece, sometimes people ask questions about using a financial advisor, somebody like us, or maybe existing financial advisors, or maybe this is just a role that you or a family member would take in terms of acting in-house as a financial advisor. Like, how do you use professionals in the financial services industry to sort of best effect? Well, you want to think of it one of two ways. I think a financial advisor can help proactively, meaning before any decisions need to be made, come up with a plan that's flexible enough to imagine with you a whole bunch of different possibilities, and then work in advance of the kinds of decisions that need to be made, depending on what a path of care might be. Here's the best case scenario from a healthcare standpoint, and here's some best decisions to make financially. Here is a more concerning path from a healthcare standpoint, and here are some decisions that can be made. But proactively, you kind of map out your path into the future, and a good financial advisor might be able to put those scenarios together with you to make decision-making in the future a little bit easier. That's one way to think about getting good help from a financial advisor. Reactively is the other one. You know, after something happens and after circumstances change and priorities are changing, a financial advisor, a good one, can help you reorganize your sets of priorities and then realign all of the sets of financial decisions based on the new circumstance that you're in. And this is a little bit more crisis intervention for some families, and then it's a little bit more maybe just thinking ahead because things might be on a little bit of a plateau. But proactively and reactively are two different ways to think about working with financial advisors of your choice, whether it's a professional or somebody serving internally. Another thing that financial advisors can sometimes be a good foil is making sure that the choices that you make and the behavior that you've got financially are sort of aligned together. Sometimes people will talk about, the most important thing is to make sure that a loved one gets extremely high quality care for as long as possible, no matter what. But when it comes time to make sure that there's good decisions to fund that kind of care, there's resistance. And there might be new priorities that come up. I don't want to sell a vacation home, or this has been a favorite security of mine for a long period of time. Good financial advisors can help you align whatever the most important priority is. The financial decision making can ensue after that. I always like to use sort of a metaphor that says, you in control of finances, you're the dog and the money is the tail. You want to make sure that the way that financial decisions are being made are consistent with the goals and the priorities that you've got. You shouldn't just leave your finances, unattended, and that you have to sort of react to them. That's something that we really want to sort of zero in on. Help qualify subjective priorities. Sometimes a good financial advisor can help families sort of navigate not just roles and responsibilities, but implications of different folks making different kinds of decisions. And the way that a lot of times we do that is to come up with measurable benchmarks. With all of the ambiguity associated with planning for care, a good financial advisor would be able to give you some pros and cons of different choices, not just reacting to the medical and the family realities, but also more measurably, if you did this, it might have this tax implication and it might have this liquidity implication and so on. Quantifying benchmarks, I think, are something that a good financial advisor would be able to help out with. And this process, I'll sort of close with this too. A good financial advisor could help you manage this process too. Again, a lot of times families sometimes can step into this role and very effectively organize, evaluate choices, formalize a particular plan to move forward, execute on that, and have a monitoring function. And sometimes it might make sense to delegate some of the responsibilities of this process to a third party. There's no best answer for everybody. I'd invite you to sort of think through what kind of choice makes the most sense for you. But I'd sort of close on this. You know, when you're thinking about caregiving, you've got a lot of choices to make, and at least as it relates to managing somebody else's money, you know, not deciding what to do with managing somebody else's money is still a choice. And I would just come back to the place that we started. I'd invite you to think about that fiduciary standard, about what is the standard of care of stewarding somebody else's money while attending to some healthcare issues. Are you meeting the fiduciary standards that you should? And a good path forward is that regular process. You know, even though it's sometimes simple, going through it, I think, is a great place to start if you're unsure. And that really sort of wraps up to the best practices that financial advisors typically go through to sort of meet the best standards that we've got professionally. And with that, I am going to sort of close on this. What I'm going to do in a second, Lindsay, is in the chat, I'll give this information again when we move to question and answer about ways to contact us. But I'd invite during the question and answer side of things, if our audience has more specific things about portfolios or taxes or any of those sorts of things, I wanted to make it as open as possible and to leave the appropriate amount of time that we can go into those details. So that's the close of my presentation. Thank you.
Thank you so much, Tom. We really appreciate you kind of delving into the very different types of things to consider when it comes to being fiduciary for someone. So thank you so much. We do have a few questions that have come in. The first one is, when becoming a power of attorney, would you then be liable for care of that person in the eyes of the state?
It's a good question. So if you become power of attorney, the easy way to think about it is that kind of authority means that you're recognized to act as if that person would be acting in their own best interest. I want you to think about it like you're stepping into their shoes, all right? And whatever authority that they have, you have now as a power of attorney. So when you think about a fiduciary standard of care, and Marquita, the question was, are you responsible for their care and their cost? You're responsible to make decisions about their wealth, and ostensibly, if you also have a medical power of attorney, about their health, that are in their best interest. And you're responsible to do the best with what you've got out of the money that they would have been managing for themselves. But that's different than, are you personally responsible for going out of your own pocket to pay for stuff. The fiduciary standard is you have to act as a power of attorney as the best version of how that person would be managing their own stuff for themselves. So think of it that way. And there can be liabilities with that. People get sued sometimes with not doing the job right. Certainly you can do things like steal money and bad stuff like that, but you can't just phone it in and not do anything either. So that's part of the reason that I wanted to go through what this fiduciary process was. But there's no personal liability for you to pay for their care out of your money, but you do have a responsibility to steward somebody's wealth to the best effect for their own well-being.
Thank you so much. The next question is, how does paying for long-term care change my tax situation?
Great question, thank you. And this is going to vary quite a bit from for different households. But the most important thing to remember is, overwhelmingly, the cost of care is tax deductible. If you are writing checks for help coming into your own home, if you're writing checks for the cost of care for something like Insight or a memory support, assisted living, or so on, these are considered itemized medical expense deductions on your tax return. And the reason, Marquita, this is important is sometimes, as you can imagine, the cost of care over the course of an entire year, it could be pretty significant. More reasonable options of community care or insight are one thing, but if you're thinking about dementia-specific facility-based care, it's regular in the Washington area for costs to be $100,000, $150,000 a year or more. And the reason I mention that is paying attention to the tax implication of those costs of care. That is a huge material variable that can help make best decisions about other parts of your money. And I'll give you an example. We serve a client right now that is going $14,000, $15,000 a month out of pocket to pay for memory support in a facility. And what we figured out by doing a good scenario is the tax deductions associated with paying for the care meant that this person wasn't really going to be owing any income taxes at all. So the first thing that we did was we lowered to zero all of their tax withholding on their Social Security, on their pension, on their IRA distribution, and so on. Because if the deductions are large enough that you don't owe any income taxes, well, then don't pay any income taxes. That's our advice. But in this particular case, the tax deductions were large enough that it made sense to actually pull money out of somebody's retirement account, even more than the minimum amount, because we would be able to take up to a certain amount and not owe any income taxes on that distribution. So the taxes, and it's good, again, it's hard to give a presentation about the taxes because it changes so much depending on who in the audience we're talking to, but projecting the taxes forward is a huge part of good planning and evaluating choices. And one piece, when you're thinking of dementia or cognitive impairment, you know, we listened to Dr. Bicksel and we know a little bit about the progression of the disease. It's unlikely that care needs go down. You know, it's likely and hopefully that they can stay on a plateau for a long period of time, or they might increase. So it's sometimes a rule of thumb, depending on the patient, that if somebody's needing this amount of attention that costs this amount now, it's probably going to be that way or higher as long as that person is around, and that sometimes can help with the tax planning. But thank you for that question. That's an important one.
Thank you so much. The next question is, are the basic advisory services offered by major fund groups such as Vanguard or Fidelity sufficient to deal with the planning for those with dementia-related expenses?
That's a good question. Well, there's sort of two different ways to answer it. The first way to answer it is a lot of the large institutions that can do some projections forward, you know, they've got, for example, the software that they can plug different scenarios in and project it forward and maybe be able to, for decision makers, have a general understanding in that organization phase. But if you have a lot of those financial planning services that comes from those big institutions that you think of it this way, that you don't pay extra for, then there's usually some limits about how in-depth or how customized or tailored those financial planning services can be. So if you're speaking, and I'm addressing the questioner, if you're speaking about, you know, folks that can get like one free financial plan a year, you just want to make sure, well, can I come back to you? Can I change scenarios as my healthcare changes? Do you think about things like, use my tax example? The answer is maybe. I would ask maybe in the organization stage, just as a place to start. But I think once you get into the customization and the tailoring, you might find that folks that do a little bit more specialized work in that would give you more accuracy in terms of the sets of choices that you might have.
Thank you so much. The next question is payout from LTC insurance taxable?
Oh, good question. Happily, the answer is no. And for anybody on the call that has existing long-term care insurance as part of your coverage, that's great, because you might find that for new customers looking for long-term care insurance, it's very difficult to get qualified coverage right now, quality coverage right now. It's really expensive and hard to buy. And if you do have it, the reason that question is important is the benefits are hugely valuable. Not just are they not taxable, but they might have a real significant impact on the financial security and the availability of different choices? So it's a great question.
Thank you. The next question is, if an individual has their assets, including their checking account and a revocable trust in which they have a trustee, will the bank recognize a POA?
Okay, so good question. So the difference between assuming control under a trust and assuming control under a power of attorney, we already talked about power of attorney, and it's like you're stepping into somebody else's shoes. Imagine a trust is something different. A trust is a legal document that gives specific instructions on what to do with money that's already in the trust. So think of a trust like a bucket and all sorts of different accounts and investments inside of the bucket. And then your role as a trustee is a list of instructions on how you're supposed to behave and make decisions about everything that's in the bucket. That's a little bit different than a power of attorney. A power of attorney has a whole lot more freedom of action sometimes. And they've got different ways that they've got to qualify for recognized authority at financial services institutions. So like a different bunch of forms, different authorizations. As a trustee, sometimes it's a lot easier for financial institutions, particularly, remember when I said read the document? Particularly if you're named as a trustee in the document, you might not have to show proof of diminished capacity or cognitive impairment or something like that in order to assume your decision-making role. Sometimes you do. Sometimes as a successor trustee, there's language in there that says you can only assume that stewardship under some specific circumstances. But the other sort of distinction is powers of attorney, general powers of attorney usually can have a larger band of decisions sometimes. Look particularly for powers of attorney to make sure they allow you to buy and sell real estate. But differently on a trustee, you're responsible to do the stuff that you're supposed to do in the trust document only specifically for the investments or the property that's in that bucket. So that's sort of the distinction. They overlap for sure. And a lot of times good attorneys or good legal planning will have them work in tandem.
All right, I think we have a minute or two left to go over two more questions. How valuable are planning services for low income, low wealth, or unknown wealth situations?
How valuable? The value of those kinds of plans, in my opinion, is making sure in the organization stage that you identify all of the different resources that you might be eligible for. That's, I think, the true value. Folks that might have more limited means and more limited choices from a financial standpoint really have maybe an increased importance in making sure that if they might qualify for aid and attendance in veterans benefits, if they might, under certain circumstances, qualify for Medicaid, as long as the healthcare and the setting all line up. You know, those types of financial planning services in terms of identifying all of the right choices, that's the huge value that I think. I think when you get into, you know, some of the financial plan stuff with the big taxes or the big investment stuff, those are going to be less valuable. But I would say that making sure that you're identifying all of the different resources with local, state, and federal eligibilities, that's going to be where the real value is.
Thank you so much, Tom. We really appreciate all of the knowledge that you crammed into 1 hour. I know there's many more things that you could go through, but thank you so much for being here. And we'll go ahead and turn it over to Lindsay.
Great. Have a great morning. Thank you.
You too. Thank you.
All right, thanks to both of you and especially to Tom for sharing such important information. And now we're going to take another 5-minute break, okay, till 11:25. And please do come back in 5 minutes because we're going to have a panel discussion of family caregivers that you really won't want to miss. So we'll see y'all back here at 11:25.
Hi, Lindsay.
Hey, Tom. All right, if our other panelists want to just check in while everyone's on break, that would be great. So if we've got, let's see, we find everybody.
Lindsay, can you hear me?
Yes, but I don't
Okay.
see you yet.
I know I can see myself up there, but I'm trying to get off. I'm okay. There we go.
I see you, but you're sideways.
Yeah. I don't know.
Okay.
I need some help fixing this. Let's see. Where did I go? Oh, here I am. Okay. Okay. Video settings. This is real. Oh, I see it.
Oh, you're getting there. All right. Hey, Michelle, Annette.
Hi, Lindsay. Hi, everyone.
Hi, thanks for being here.
Yeah, thank you, ladies.
All right. And let's see. I don't see Elizabeth yet. I see her logged on. But I don't see her video. Elizabeth, do you hear us?
She's here. I see her.
You see her? Okay.
I see your video.
Okay.
Yep.
Oh, there she is. All right. Elizabeth, do you want to check your mic and make sure everything's all set? All right, I'm sending you an unmute request.
You know?
There you
Yes, you
Oh.
just want to get a little closer to the computer if possible.
Okay.
Okay. All right. Well, great. So everybody's on a break. I mean, everyone sees and hears us, but we've got about 2 minutes before we get started. So you can either leave your camera on or off, and we'll get rolling in 2 minutes. And by golly, it's already 11:25. These breaks fly right by. I hope everyone had a chance to stretch their legs, refill their glass of water, and settle in for our last hour together. Our third session this morning is What I Wish I Would Have Known. And this will be some perspectives from family caregivers. And our two facilitators for this last session will be Marquita Brown, our support and outreach coordinator at Insight, and Ellie Patoni, who's an intern in her Master's of Social Work degree and also a social worker at Insight. So we know and love her for many different reasons. So I'm going to turn it over to these lovely ladies to lead us through our last presentation this morning.
Thank you, Lindsay, and thank you everyone for coming back to us. I know we are very excited for this panel. It is something that I think will be very valuable to many people and really helps us a good way to end the day. Okay, so Marquita and I would like to officially welcome you to the Family Caregiver panel, where we have the pleasure of speaking to 4 caregivers about what they wish they would have known as they transitioned into their roles as a caregiver. But before I introduce our caregivers, I would like to first take a minute to mention a few items about today's panel. Each of our 4 caregivers will have approximately 10 minutes to share caregiving topics that they wish they would have known in their journey to help advise you along your path forward. Next, we will invite each caregiver to join us in a brief collaborative discussion where they will have the opportunity to answer additional questions from the panel facilitators and share any additional input. We will then follow up with a 10-minute Q&A session. Therefore, we encourage you to submit any comments, questions, or concerns into either the Q&A box or chat box at the bottom of your Zoom screen. Just as a note, the chat box is able to be viewed by other participants, but if you have a private question that you want to ask, please submit those into the Q&A box. You're welcome to submit these comments, questions, or concerns at any point throughout the presentation, and we will be happy to respond to them once we are done. With all of that said, I would now like to introduce our 4 caregivers who have graciously agreed to donate their time to provide further support and guidance for our audience. First, I'll have the pleasure to introduce Maureen Crystal, who is currently caring for her husband, David, at home. Maureen and David are no strangers to Insight Memory Care Center's services, as they completed the SHARE program with Lindsay, and David has previously attended the Early Stage Reconnections program. Then I will have the pleasure to introduce Michelle Lynette Hughes. Michelle has been supporting her father as a secondary long-distance caregiver for her mother. Our third caregiver who will be speaking today is Tom Holloway, whose beloved wife, Elaine, previously attended the Adult Day Center before transitioning into a full-time memory care facility. Finally, we will be joined by Elizabeth Pan, who cared for her partner, Wayne, at home until he unfortunately passed away. Elizabeth and Wayne have also been a part of the IMCC family, as Wayne previously attended the day center and Elizabeth regularly participated in our IMCC support groups. So I would first like to start our discussion by speaking with Maureen Crystal, who, as I previously mentioned, who is caring for her husband, David, for the last 8 years. Maureen and David have completed the SHARE program, and David previously participated in the Early Stage Reconnections program. Maureen, I am sure I can speak on the behalf of our organization when I mention that we appreciate your collaboration during this session to help other caregivers such as yourself. Maureen, would you like to introduce yourself and take 10 minutes to share with our audience the topics that you wish you had known at the beginning of your journey?
So Maureen, you're on mute.
Okay,
There
can you
go.
hear me?
Yes.
Okay. Still hear me?
Yes.
Okay, great. Hi, everyone. It's really difficult to talk to just a screen and not see your faces. I really dislike this whole, process that we have to do online, share our deepest pain and sorrow and all these intimate things we go through online. I really prefer the in-person setting, but hopefully the world goes back to something that good. My name is Maureen Crystal, and my husband got diagnosed almost 7 years ago, just in this week, or our anniversary will be the October 9th, and it would have been our 20th anniversary when he got diagnosed. So anyways, I guess that makes me an old timer to share advice with you. What I'd like to say is that, going to those meetings, I went to Sarah Harris's early onset support group meeting in Fairfax. And, as you sat around the table, you would hear the old timers tell about their stories or different things that were happening. And Sarah said in the first few years, she never thought I was going to survive. I was just distraught from it. And so those stories, though, stay in your brain, and they help you with your path forward as you think about what may or may not happen to your loved one. just, hang in there. Take those stories, absorb them, and then move on. But I really found that it's hard, and I mean as hard as it was to hear those stories. They just helped me a lot. I like a lot of like songs and slogans and different things to help myself get through this. And one of the slogans, or it's actually I'm going to paraphrase Bob Marley, the reggae singers. He has something, and this is, you will never know how strong you are until strength is your only option. And that's what we're facing. You just have to be strong. And it's your only option. And the other thing I really try to do is attempt to look at the situation with a glass half full versus a glass half empty. I'm always trying to convert whatever's happening to me into glass half full. For example, my husband, my beloved husband, is going on to his 8th year. And as many of you know, the projections for life is 8 to 12 years for some after diagnosis. And, and instead of seeing it as glass half full, I have to say, I've been married to, my dream partner. I love him. And also my husband doesn't have behavioral issues. He's just sweet and wonderful. And so it's allowed me to keep him at home. And my goal is to keep my husband at home with me through the entire disease. I want him to die in our bedroom with me next to him. And that's not a judgment statement for people who, I've been in support group meetings where people are just dealing with, behavioral issues that are intolerable, and they can't keep their caregivers safe. So, they place them in memory care. Mine isn't a judgment statement. It's just my goal to keep my husband with me the entire time. And glass half full, he doesn't have behavioral problems that require me to place him in memory care. So on my journey as, the old timer, I want to tell you that there were a number of things that I did that I thought helped me best. One was to assemble Team Crystal. And first I got an elder care attorney, Jessica Pinnell. I'm sorry, she has a new name. I can't remember it right now. And she referred me to Tom West, who you just saw. And Tom referred me to Insight. You need to assemble your doctors, your neurologist, your psychiatrist, if you go into depression and need medication, your therapist to deal with the grief. Tom's going to talk about a term I had just learned when I looked at the agenda was anticipatory grief. And you need to look at places like my husband attended Friends Club and Insight, and Friends Club is in Bethesda. And you need to do that. And to start now assembling your team. Second is Tom suggested I do the SHARE program here at Insight, and it was the very best thing I did at all, completely. What you do is you sort of outline the caregiving network and support you're going to need as this disease progresses. And the sooner you do it, the better off you are, because the actual, my husband was participating with me, and we were deciding, what we want. And so the earlier you can get it where your loved one is able to participate in that program, the better off you'll be. There's a professor from Georgetown named Stephen with a V, Stephen Sabat, S-A-B-A-T. And he writes a lot about Alzheimer patients still being able to make memories. And for example, my husband hasn't been in one of the Insights in 2 years close to 2 years because of the pandemic. And just the other day, he woke up and said, which group am I going to today, Maureen? I mean, you know, he remembered that. And you know, he's late stage now. So, and he talks about in one of his, he has a lot of YouTube things that you can easily watch. He talked about a woman going to like, you know, like an Insight, but she would bring her makeup bag and sneak it in, and then she would go and put makeup on while she was there. Now, this woman's got Alzheimer's, but she's still, you know, bless her heart, still cares about how she looks. And he talks about things like that. And he's excellent. Let me just say, I'm not trying to endorse anybody that I'm getting kickbacks, nothing like that. I'm just telling you my journey and who's helped me. The last thing I want to say is that my husband participated in a lot of the studies at Georgetown's memory disorder clinic. And if you participate with them, you get more back than you ever give. I mean, you know, you give invaluable information to them. But for example, my husband has been through numerous studies there, and, you know, you take him monthly, you get a free lunch, they pay your parking, but they're examining him on a monthly basis to see where he's falling in his memory and his health. And it's a very interactive process that for me was wonderful. My husband was able to do a trial drug there. And I know without a doubt, only 50, I think it was 54 people across the country, and it was a blind study. So my husband, you know, we didn't know whether he got the actual drug or a placebo. Well, he got the actual drug, and I knew that because of how well he was holding up and then how quickly he deteriorated right afterwards. I think that gave us an extra year of my husband's life. But unfortunately, you know, the isolation that we've experienced from COVID and how terrible it's been on us, I think that he has lost years from COVID, not getting it, but just the side effects for people with Alzheimer's and their caregivers. I'm just now getting in touch with how devastating, catastrophic it has been for me. What I think is that there really needs to be a paradigm shift in the care for families with Alzheimer's. Everything seems to be focused on the patient, you know, the tax laws, if you want to, you know, get any benefit from tax laws for, you know, excessive mental, healthcare. You know, it's all about the patient. But I really think that it's the caregiver, because in my opinion, if I'm doing okay, I know my husband's going to do okay. But if I'm not doing good, it's a direct impact on him. And I want to tell you a story. My husband, I got flipped off on my screen. Am I still okay?
We're actually wrapping up on the time. And so if you wanted to make some last comments before we transition to the next person.
Yeah, okay, I will. Boy, that went fast for me. I'm sorry, I had a lot more to tell you. But what I have to say is that when my husband got diagnosed by Georgetown, I left my body. And about 6 or 8 weeks ago, I just realized that this entire 7 years I have been missing in action. And I am just now getting in touch with all the crazy behavior that I went through with this grief, and how it just took me away, took me out of myself. And so I guess what I'm going to say is it's a journey that you really need to do self-care. You just have to focus on you, because if you focus on you, everything, your family, we have small children, everything you need, everything depends on you, the caregiver. You're the important one. So please take care of yourselves.
Thank you so much, Maureen, for just all of the insight about, you know, having the glass half full, aging in place and making the distinction for individuals that decide to make that transition. I really appreciate it. Slogans definitely help. If you need support with, transition or making a plan, definitely inquire more about Share as well, and building your team. Thank you so much, Maureen. That I know it's probably so many more things in the plus 8 years that you've been that you could say, but thank you so much for sharing.
All right. Thank you. So our next caregiver that we will have speak is Miss Michelle Lynette Hughes, who has been assisting her father for the last 12 years by taking on the role as a secondary long-distance caregiver for her mother. Thank you, Michelle, for taking some time out of your day to participate in this panel. Would you like to introduce yourself and take some time to discuss what topics you wish someone would have told you at the start of your journey?
Yes, absolutely. Hello to everyone, and thank you so much to the organizers for this as well as everyone else taking time out on a Saturday morning to listen to what everyone has to say. When people say, how's your mom have made it 12 years, essentially we've had her at home the whole time. I'm a long distance caregiver. My parents are in Harrisburg, Pennsylvania, and I'm in Northern Virginia. So it's about 2 hours away from here. So it has been challenging. Things that I wish we had known, which we didn't know how bad the angry stage could get. And typically from watching other friends and family members, as well as going to the support group, the angry phase can last for as long as 3 to 4 years. And so sometimes you may lose your sanity during that time. But the best thing I've learned over the past 12 years, especially the angry phase, is to lower the expectations that your loved one's hair may not be perfectly done every day. You may not have time to prepare the meals that you wanted to prepare for them. So that's something that we've learned to lower our expectations. In addition, I learned in a support group, but I just somehow thought that it wouldn't be relevant to my mom, who's now 76. So she was diagnosed in the early part of her 60s, that the Alzheimer's drugs, Aricept and Namenda, eventually lose their effectiveness, which, I mean, you don't know exactly when, but you notice that maybe they might lose the ability to walk and things like that, or communicate or respond to things. And typically with us, it happened at about year 8 that it stopped being effective. So she's not on Aricept or Namenda. She's just on drugs right now to counter the symptoms and effect of Alzheimer's, which would be depression. And then the most recent med that she's gone on is clonazepam, which I think is spelled Clonazepam, and that helps with the muscle twitches and the jerks, and it's given at nighttime. Something else I wish we had known, other than the monetary aspect, which once we got into the disease, I guess about year 8, it started costing us about $3,000 to $4,000 a month for caregivers. And although that would probably be higher in Northern Virginia, my parents were in Harrisburg, Pennsylvania, and so it's a little bit lower cost there. Let's see, I'll address the wandering. My mother always walked pretty fast, and in addition to the angry phase, when she would wander, that would get worse. And so we put alarms on the doors, and whenever we would go to visit someone's house or a hotel, go on a trip, we bought these cheap bells from the dollar store, and we put them on the door. So if she would go out or such, we would hear her going out. Let's see, we did actually lose track of her at one time. We were at a family reunion at night, and we thought everyone was asleep and secure. And I guess about maybe 12 midnight, my sister and my nephew realized, oh, she's not here. So we go wandering throughout the hotel to try and find her, and come to find out she was sitting in the lobby. And when we asked her, where was she at, what she was doing, she was like, oh, I was downstairs in the lobby waiting for a tour. So it was funny, but not funny, because she ended up getting lost at like 12 midnight or 1 o'clock in the morning. Let me see what else. Currently, my parents are in an independent living facility. I did manage to sell their house in February of this year, which dejunking a house after 35 years, it just, really kind of took a major toll, but that was done. So they're in an independent living facility. I mean, they get 3 meals a day. Let me see. I would stress to everyone that if you have any indication that your loved one may be developing Alzheimer's, definitely get an evaluation from a neurologist. And neurologists there can suggest an MRI, which you'll actually get verification that your loved one has Alzheimer's or dementia. And so that was pivotal, but fortunately we didn't get the MRI with my mom until year 4 of the disease. And that cost us precious time, in addition to my father and my sister kind of being in denial that she actually had Alzheimer's, although I first saw it in 2007, but the diagnosis wasn't made until 2008. And so that kind of cost us precious time. So get an evaluation by a neurologist, even if it's, in the early stages or you think it's nothing. The primary care can say, hey, let's get you to a neurologist and get looked over and get started on Aricept and Namenda, which are the Alzheimer's drugs. So in hindsight, once I had an indication or a thought that my mother may have Alzheimer's dementia, follow your gut instinct, because with other family members, oh, she doesn't have it, you don't know what you're talking about. And I'm a medical professional, so I kind of knew. So I wish I would have jumped on a little bit earlier. Also, things I had known that early in the stage of Alzheimer's, as long as they can walk and you can feed them, they can still go on trips. So what we did is we actually went on a cruise, and then we went to New York City to see a play. So those were things that, took a lot of time and energy and planning, but we were making those memories. Also things I wish I had known, continue to play music. At the point where my mom is now bedridden and she's in Depends and she's on hospice, which, by the way, hospice doesn't mean that they're going to die right away. It just means that they have a terminal illness that they need care for. So even if they're bedridden and Depends and they're eating pureed food, continue to interact with them and talk with them just like, they were fine. Playing music, I really key and stress music, whether it be for music that they listen to in their 20s or their 30s, but music kind of always elicits some type of reaction out of her. Let's see, and I'll comment on a hospice that my mom gets. People think, oh, you have to be absolutely dying or at the end stage, but you can get hospice like the last 18 months. So hospice comes Tuesdays and Thursdays for 4 hours from 8 a.m. to 12 noon. And then Monday, Wednesday, Friday for an hour. Obviously, as my mom gets more terminal or has more swallowing issues, and hospice may come more. And then a nurse comes every other week for like an hour, and we're in touch with her. But she's very comfortable. Hospice provides like 2 wheelchairs, one sitting up that we can get in the car, and the other one that's huge where she can lean back because she has a slumping right now. So, gosh, trying to think where I'm at in the, okay.
Did you have any other? Okay, you went through a lot. You did some speed flying through years. So thank you so much for, just a couple of highlights that you mentioned, just the monetary considerations, the lowering expectations in the different stages, particularly in the angry stages, educating yourself on how to maneuver through those, difficult times. Like she was mentioning, evaluating, getting yourself evaluated or getting your loved one evaluated as soon as possible, and getting on those drugs, because eventually they do have lose their effectiveness over time. There's so many different nuggets that you trusting your instincts, using sensible ways to monitor your loved ones. Some things can be expensive, but there are some other ways, as was mentioned, and utilize those precious times, while they're still mobile. It may be more difficult, like was mentioned, more planning, but utilize those times to still do what you love. But just because there's a diagnosis doesn't mean that there's not a quality of life that can be had. So thank you so much, Michelle. We really appreciate you mentioning so many good nuggets during your session.
All right. So I'd like to move on to our next caregiver by introducing Tom Holloway. Tom has been the primary caregiver for his spouse, Elaine, who previously attended the Adult Day Center before transitioning into a full-time memory care facility. Welcome to the panel, Tom. Would you like to introduce yourself and share some information you feel could have helped guide you at the beginning of your journey?
Thank you, Ellie. As all of us know, caregiving is hard. I remember Lindsay telling us in one of the training sessions years ago that being a caregiver for someone with dementia requires us to be both a detective and a magician. A detective to figure out what those strange behaviors mean, and a magician to make everything fall into place at the right time. I wish that I had realized earlier that it's okay to accept help and even to ask for it. That's actually a sign of strength, not of weakness. I was determined to take good care of Elaine because I love her. The saying that in times of adversity, in times of crisis, those who are the strongest are the ones who go for help is something that I wish that I had realized earlier. Caregiving is a team sport. If we don't have an excellent cohesive team, we're going to burn out. And self-care is not selfish. Maintaining routines for ourselves of healthy eating, exercise, drinking water, getting our own medical checkups, giving grace to ourselves and to others, and exercising gratitude and faith. These are some of the best things that we can do for the people that we care about. I've organized my thoughts into 4 buckets. This first one was teamwork. The other 3 are frustration and grief and community. Moving on to frustration. I wish that I had realized much earlier that Elaine was not being difficult on purpose or intentionally trying to make my life difficult. The virtual dementia tour that they gave at Insight Memory Care Center was very effective in letting me experience for just a few minutes the intense frustration that Elaine was going through every day, all day, 24 hours a day. That gave me a measure of grace in dealing with her, and that measure of grace was essential for my own health. Because the beautiful young woman that I married 53 years ago is still in there, even though she's no longer able to speak, and I do want to honor her. I see her about once a week. About a week ago, I went to visit her, and I realized how much love there is still there, even though I have not been able to understand anything that she has said for over 2 years. The next bucket that we would like to consider is grief. I wish that I had understood grief earlier. I found myself in the role of caregiver, and that was uncomfortable for me. Because my major was chemistry, I liked things that were nice and logical and organized. And when you put 2 chemicals together, you know what's going to happen each time. And I found caregiving a much more complex form of chemistry. You never know exactly what's going to happen when something happens with our loved one. I was grieving. And I was grieving the loss of her capabilities, the loss of opportunities to travel, the loss of time and ability to plan together, to go for walks together, to go out to dinner. And everyone is different. And so we, even though grief is a universal experience, each of us experience it in our own way. I recently learned from a grief seminar that Hope for the Heart provided that there is anticipatory grief, and that often the grief that we go through before someone dies is worse, more intense than the grief when they actually do die. And so I and many of us are going through that anticipatory grief at this time. The next bucket that I'd like to cover is community. Our culture tells us to brag about our accomplishments and hide our struggles. I wish that I had realized earlier that that is a path to isolation. People who are going through the same things that we're going through can provide a lot of comfort and strength and friendship. It's vital to reach out, to both help others and to receive their help. And I am immensely grateful for the support that I have received from many sources. My church family at Graceway Baptist Church has provided a sounding board for me as I have faced some very difficult decisions, like deciding to put Elaine into a memory care facility when I realized that I could no longer physically provide all of the help that she needed, even with help from paid caregivers and the wonderful support that I received from Insight Memory Care Center. Insight provided education for me. The education programs that they provide and the support groups are wonderful, and we've experienced one outstanding example of that today. And Ellie and her colleagues provided daily care for Elaine, and that was a real joy. And Ellie, it is so wonderful to see you again. I appreciate support from the medical community. This past year, I've gone through chemotherapy for lymphoma, and I'm very grateful to have a very good result from the latest PET scan. I'm grateful for support from my boss and coworkers. My boss told me, Tom, I was getting worried about you, but now that Elaine is in the memory care facility, I no longer am worried about you, but they have been a wonderful support. I do attend a support group just about every week, and I'm grateful for my colleagues in Toastmasters because the experiences that I've had as a caregiver provided a wonderful topic for a speech in Toastmasters, along with the lymphoma treatments. This week, I was listening to the radio. I heard a perspective. It was on the Family Life Today broadcast, where Dave Wilson, the host, gave us this perspective. He talked about how we enjoy very much the mountaintop experiences that we face, but most of the time we spend our lives in the valleys where things are very difficult. He gave these perspectives that God does his best work in the valleys when we don't realize that he's working. He said that our pain invites God's presence, that God can use our pain to help others if we let him, that God wants to use our pain to help others. He said he has a sign in his office before he goes to preach. Never underestimate the pain in the room, and never underestimate the power of Jesus to transform our pain into power and purpose. I hope that what I have gone through can help you get through what you're going through. For me, that will be a redemptive purpose in the pain. And if you'd like to contact me, I'll put my email address into the chat.
Thank you so much, Tom. We really appreciate all of the things that you and giving your insight for. So for any of you that were taking notes, get your inspector gadget together. If you want to become the magician, like he was saying earlier with David Copperfield and Harry Houdini, it is a hard task. And so we just thank you just for reiterating, it's okay to ask for help. That's actually a sign of strength, as was mentioned. Caregiving requires a team. Self-care is not selfless. Maintaining routines is very important. And there's so many great nuggets of gratitude and faith. And so we thank you so much, Tom. And we're going to go ahead and move on to the last but not least. So go ahead, Ellie.
All right. Thank you, Tom. It's always nice to see you too. So our next caregiver that we're going to speak to is Miss Elizabeth Pan, who cared for her partner Wayne at home until he unfortunately passed away in 2020. Elizabeth's partner, Wayne, also attended the Adult Day Center for a while, and Elizabeth regularly attended IMCC's support groups. Thank you for joining our panel today, Elizabeth. Would you like to introduce yourself and share some of the topics that could have been helpful for you at the beginning?
You're on mute, Elizabeth. I just sent you a request to unmute.
Yeah, thank you. And it's good to be the last speaker because I got so much out of the previous speakers. I learned so much from them and I enjoyed them and they inspired me. So my journey with Wayne, I'm one of the people who decided to do it at home, to take care of Wayne at home. And my journey is in 5 stages. There was an early stage of dealing with the realization that Wayne had Alzheimer's. And this was even before there was a diagnosis. By the time the diagnosis came, it was already clear that there was a problem. And that time was, I don't even know how long it was. So it's hard to say it was 3 years or it was 5 years or it was 3 months. But there was clearly a time when I needed help. So the first few years is what I would call a coping with it by myself. And that also became gradually the time when anger came out, when impatience came out, and confusion came out. And you get to a point, and in my case, the point was when Wayne fell down and I could no longer lift him and put him back in a chair. I had to call the fire department and they came to help me lift Wayne. But it was more than that because it made me realize that I can't do it anymore by myself. And that I had to move Wayne from where our bedroom was upstairs to the basement, which had bedrooms, full bath, living room, everything. And because there was an exit to the outdoors, the fire department people made me realize that I couldn't get Wayne out of there if there was a fire. but in the basement, there were doors immediately to go outside. So that marked the transition from struggle, from anger, to getting help. And I started hiring people, and I started going to insights and discovering insight. That was the key. That was like the key to the door that opened up to a gold mine. Because they not only took care of me during the day, they took care of me. You know, I learned so much from the support groups. It was like Google. I could ask any question and get an answer. Many times more than one answer. It was amazing. It was like a gift that kept on giving. And at that point in time, when I started switching from coping by myself to getting help, that I started accepting the situation for what it was. And I noticed that when I was able to accept what was there that I could not change, Wayne also started to accept it. And this became a very important point in the journey. It really marked a difference of joy. There was a possibility of joy. Not that every moment was joyous, but the possibility of joy. And at about this point, I also looked at, you know, what if I got to the point where I couldn't do it, even with caregivers? So I started looking at all the options, including assisted living and group homes. And I decided I wanted to keep Wayne at home, that I'm a control freak, and I would never be happy when somebody else is taking care of me. So it changed everything. Instead of taking care of him directly, my agenda became taking care of my caregivers. And that made all the difference in the world. I had 24-hour care in shifts of 8 hours each. And I believe that we came up with the best care program anybody could get. Wayne had spa days weekly. He got a manicure, a pedicure, a facial. That's amazing. He enjoyed every bit of it. I cooked all his favorite foods. And sometimes he had appetite and sometimes he didn't, but it didn't upset me like it used to. And then the biggest help that I finally asked for was hospice. And you know, I said to myself, hospice care, by definition, is end of life care. For people who have a condition that cannot be cured, that there is no fix for. And what is Alzheimer's than a condition that cannot be cured? So why do we put a time frame on hospice? Get the help that you can get from hospice as early as you can, as early as you are comfortable. Hospice provides supplies, diapers, and ointments, and everything that you can imagine that is consumable is provided for free. I discovered that hospice provides equipment, not just the hospital bed, but also lifts to move the patient from one location to another. Equipment that I didn't even know existed. They provided people to come and show my care team how to bathe Wayne, how to move him without hurting themselves. Hospice provided expertise. They had a chaplain come. And Wayne loved church music. And this poor chaplain sang the songs. He was totally tone deaf. But Wayne loved it. So I would urge all of you to consider hospice, and also not to ask hospice to do an evaluation to qualify a person for hospice, because they have to follow Medicare standards, Medicare guidelines on what constitutes readiness for hospice, what constitutes eligibility for hospice. Instead of doing that, oh, by the way, I did that and Wayne got rejected. Why? Because he didn't lose his 60 pounds within the last 3 months. He lost it prior to last 3 months. The fact that he lost it not within the last 3 months, they couldn't check off that item on the list. I wasted a few months because I went to hospice to do the evaluation. What I discovered is that I could go to Wayne's doctor, and because she believed that he could benefit from hospice, she wrote the order for hospice, which qualified Wayne without an assessment by hospice. Anyway, when it came time, and this I direct particularly to Maureen, I was in bed with Wayne when he died. And I didn't know it, but that made the decision of caring for him at home worthwhile. When I noticed his breathing change, I remembered he had a favorite song. And I finally found it on YouTube, and I played it for him. But there is one more stage after his passing, and that is the stage of gratitude. The dominant feeling I experienced was gratitude. First, to Wayne for giving me this unique opportunity to grow. To all the people who helped. Especially his caregivers. To Insight and all the people I met through Insight, who really taught me so much and inspired me.
Thank you so much, Elizabeth. We really appreciate just a heartfelt, just expression of those, last moments to all of you all. I mean, even with the 5 stages that Elizabeth mentioned, the coping with the different things, whether it be confusion, impatience, frustration, that I know many of you as caregivers and even, us that are on the team at Insight have experienced with our personal journeys. Just having those fall risks happens, those events that happen to make you realize, okay, I need to really, reach out for help. And then the journey of, if you're going to be aging in place with your loved one, restructuring this space to make them safe, things of that nature. But then she said something really important, finding those gifts in the community. We're very, honored to be able to be a instrumental piece of their journey, but wherever you may be, finding those gifts and having the acceptance, because in the later stages of the journey, your loved one is mimicking you. They may not be able to verbally communicate. However, once you show through your tone, through the way you do things, as stuff shifts, and it's not easy, as everybody has mentioned, they will start to accept and feel more comfortable with the process, even if they may not be able to communicate it. And so then when you're able to do that, she said something very beautiful. The possibility of joy can take place. And, just being able to transition if you can, no pressure if you can't, but being able to transition that thought of, okay, I'm going to take care of my caregivers now because my needs are taken care of. Knowing when to engage hospice, so many things, so many nuggets. Thank you so much. In terms of even keeping them engaged, everyone has talked about, even though they may not seem to be there, making sure we engage with our loved ones. So we do have a couple of questions. I did allow it to extend a little bit because the things that everyone, contributed was so rich. We do have a few questions and we have maybe about 7 minutes to go through some stuff. So panelists, get ready. If you get specific question, go ahead, Ellie.
All right. So our first question, it says, question for the panel. Any insight on navigating caregiving during the pandemic? In my area in Arlington, most people are good about masking, but taking my mother with me in indoor public spaces is difficult because she frequently takes her mask off and doesn't remember or understand why we should keep it on. We are vaccinated, but it still presents a point of anxiety for me.
Would anybody like to chime in? Go ahead, Maureen, I saw you.
Mute. Hello.
Here you
hear
go.
me? Great. I actually have Lyme disease. I've had it for 17 years now. It's devastating. And I have a compromised immune system because of it. So you can imagine if I want to care for my husband through this journey, I've got to stay alive myself. So we actually quarantined for 14 months before we got vaccinated. We started to go back out into the world again, eat out at a cafe, outdoor cafe and stuff. And then Delta came along. So we actually almost exclusively quarantine. And, it's difficult. I agree that when you go out in public, my husband will, he's always pulling his mask off. I mean, I guess the only advice I have is you just have to stay right near them. It's tough. But, I gently say, hey, honey, there's a pandemic and we really need to wear these. So I don't know any other way other than having to sort of stay right on top of them to do that when you're in indoor places. So you may think about, doing more things outdoors. Instead where you're safer. Yeah.
Thank you so much, Maureen. We really appreciate it. Michelle, you can go ahead. We do have 5 more minutes, so you can go ahead next.
Okay, great. Mine is very brief. My mother is bedridden or has to be in a wheelchair. So we just really didn't go out in as many places unless it was a doctor's office. And because they were in an independent living facility with other residents. They got the mental stimulation by going to dinner, going for walks, or things like that. So that's how they face the pandemic. Mom, always kept her mask on because she didn't have the eye-hand coordination to remove it. So that's how we handled it.
Thank you so much. We do have another question. Where can I get help on taking care of my husband in the near future if needed, like daily help from someone? Anyone have any suggestions?
I do.
All right, go ahead, Elizabeth.
Because I hired a bunch of caregivers. There is a website called care.com, and it's not the only one, but that's the one I used, that posts the names and contact information and backgrounds of people of caregivers. So you can contact them if you think there's a match, as well as they post your job openings. If you're looking for somebody during the hours of X to Y, you can post that and see who applies. So that's one way to do it. I don't think it's the best way, but if you're desperate, that is one way to do it. And of course, there are agencies from whom you can hire caregivers. That tends to be much more expensive. Best way that I found out is through word of mouth. But word of mouth needs that you start with one mouth, one name, one person. And if you can find that one person, that person will lead you to many others because they're all in their own networks. And these networks are generally geographically determined and culture. So there are people who are from certain countries. They have a lot of caregivers of people from that country. And Hispanics, African countries, Asian countries. So you can pick, or the universe will send you the right one, as it did for me.
Thank you so much, Elizabeth. I wanted to mention something or expound on something you said. A lot of times, especially if your loved one has a primary language that was not English, that becomes very important in terms of culture, to be able to designate someone that closely aligned they may be able to connect in reference to that. So thank you so much. I did have another thing, I think that Tom mentioned that I wanted to highlight two things. We talked about, I think, a theme of anticipatory grief that we talk about because, even though your loved one's still there, a lot of times their personality and different things, kind of fall to the wayside. The ability to speak to them. Many of you are spouses or have a partner, or even with, if you're close with your parent, those changes definitely hit home. And so I wanted to mention something else that was mentioned. When caregiving chooses you, rest assured, we all don't come out being caregivers, right? It is a skill. And so if you ever question the fact that you're not doing enough, or as soon as you get a flow of something, something changes, know, like Tom mentioned, when caregiving chooses you, it may not be natural to you necessarily. I know he said he equated it to a more complex type of caregiving with his science background, but just rest assured in that, that whatever you need help or support with, even if you're not in the area, Insight is here and available. And if we are not the best fit for you for whatever reason, we can try to connect you to something else in the community. So with that, that is all the time we have. Thank you so much for the panelists. A definite round of applause for all of the nuggets. I tried to keep them all in my mind as you just shot them out. Just definitely a rich discussion. Thank you so much. And I'll transition it over to Lindsay.
Oh, and my thanks to all four of you for being here today and sharing so openly your stories and your learnings and helping each other, and also to my two facilitators. So wonderful. I'm just going to share my screen as we wrap up today's Caregiver Bootcamp. I hope everyone here has picked up just tons of good information, insight, inspiration, resources, a little more confidence in moving forward as a caregiver. So as we wrap up Caregiver Bootcamp today, I want to let you know that there will be a survey that pops up in your browser when you close your webinar. And we hope that you will give us your feedback about today's education event. What was valuable, what was less valuable, what are ideas for future topics that you would like to learn about? Please do give us your feedback on that survey. There will also be an automatic email that comes out from Zoom tomorrow, and there will be another opportunity to complete the survey there. We will include a link to the recording and the password to access the recording from today. So if you missed part of today's presentation, no worries, you'll be able to access that later on your own time. And there's always a lot going on at Insight. So please check out our event calendar. We offer a series of monthly classes for caregivers. They are virtual, they are free, open to the public. You can look at the calendar to see the remaining classes for October, November, and December of this calendar year. As was referenced in our panel discussion today, there can be so much benefit from participating in support groups. And Insight support groups are also free and open to the public. We have a variety of different types of groups that meet at different times of day and days of the month. You can find those online on our website. I wanted to point out the SHARE program. For those of you attending who are pretty new at this, your loved one has a recent diagnosis, maybe still in that earlier stage of the disease, and you're trying to navigate. You're trying to figure out, what are we going to do? Who's going to help us? What resources do we need? How do we even talk about this together? The SHARE program is for you. So you can learn more about that on our website, as well as our participant programs, including our early stage social program called Reconnections and our Adult Day program that meets in Fairfax. And Insight is a nonprofit organization, and we rely on all kinds of funding streams to make our services available to the public, including today's free Caregiver Bootcamp. Our biggest opportunity to support Insight is our Paintings and Pairings event, which will be virtual on October 14th. This will be our 10th Paintings and Pairings event. It will be an opportunity to hear some stories from Insight, from our families, an opportunity to interact virtually with each other. There will be an Excellence in Memory Care Award that's given. There's an online auction, and it's just a way to celebrate all of the care, support, and education that Insight offers for our members of our community. So to get your tickets to Paintings and Pairings, you can visit insightmcc.org/paintings. So I hope you'll join us there in a few weeks. And there are many ways to support Insight. We do appreciate all of your generosity to make these services available to the public. And to follow what's going on at Insight, you can follow us on Facebook, YouTube, Instagram, LinkedIn. There's always a lot going on. I know in this busy virtual world, there's a lot of email to keep track of. So feel free to like and follow us on the different platforms to keep in touch with what we're up to. And I'll just close by, again, thanking all of you for being here today. If Insight can be a resource to you in any way, please do contact us. Visit us on our website, put a little message in the chat bot, email us, call us, even stop by. We are here for you no matter where you are on this journey. So I thank you again all for being here, and I hope that you have a wonderful rest of your weekend.